Uh, Good afternoon, all of you, all the people who have registered for the PCNI conference and the National Pediatric Infectious Disease. On behalf of the conference, we are presenting a pediatric and neonatal ventilation workshop. This workshop is officially under the auspices of Pediatric Conference of North India. And we have a very esteemed national faculty today with us, Dr. Rajiv Uttam. He's the Director of Pediatric ICU at Max Patparganj Hospital. Hello. Dr. Naveen Gupta, who is the Director of Neonatal ICU at Rainbow Children's Hospital. Myself, I am at Madhukar Rainbow Children's Hospital and Vice Chancellor for the Indian Academy of Pediatrics for the Pediatric ICU Fellowship. And then we have Dr. Rachana Sharma. She's the Director of the Pediatric ICU at BLK Hospital. And Dr. Kumar Ankur, he's the Chief of Neonatology, Senior Consultant, and he's at BLK Hospital Neonatology. And with Dr. Anil Batra, he is a neonatologist at Rainbow Children's Hospital, Delhi. And then Dr. Chandrasekhar Singha, who's a senior consultant pediatric intensivist and pulmonologist. Now, all of this esteemed faculty is very, very experienced in the field of intensive care as well as ventilation. So what we have done is that this entire workshop combines the skills of neonatology and pediatric intensive care as it pertains to the mechanical ventilation. Now, mechanical ventilation, as we all know, has been a very, very contentious early for people to learn, intubation and all those things. So what we have done in this workshop, this being a webinar, and it's extremely difficult to show you all the things, but still we have tried to keep with every PowerPoint presentation as many movie clips as possible. So hope you all enjoy this workshop. And I will start with our introduction of the first topic, which is basically talking about basic mechanical ventilation. And in that, what I've done is we have just included the basic principles of mechanical ventilation, also showing you some clips of intubation, which have been recorded earlier. And then as we build it up, you will basically have some understanding of basics of mechanical ventilation, and then further topics pertaining to neonatal ventilation specific things, disease specific ventilation specific things, graphics on the ventilator, and various issues related to weaning and extubation. All those things, including the non-invasive ventilation, are included. Yes, it's a very ambitious project to do it all in 3.5 hours, but you will enjoy it because we have just kept it very, very basic, but at the same time, advanced enough for the people who are in the field of ventilation or want to get into the field of basic mechanical ventilation. So this is one movie clip that I'm just going to show you. This was just recorded many years ago, but it pretty much shows the intubation and ventilation process.
प्रवीण साउंड नहीं आ रहा. Praveen, there is no sound.
Acha, there is no sound?
No.
Wait. Let me ensure. Is it my sound not available or the movie clip sound?
You are audible, but the video is not audible.
Okay. In any case, it is a lot of visual in it, but I will ensure that its volume is also increased to the maximum.
सर जब शेयर का ऑप्शन आता है सर नीचे उसका ऑडियो का ऑप्शन आता है उस पर क्लिक करना पड़ता है सर.
ओके.
शेयर स्टॉप करके दोबारा शेयर कीजिए सर नीचे आएगा ऑप्शन.
ओके एक मिनट. Your स्क्रीन शेयरिंग इसमें आएगा स्टॉप शेयर। ओके, इसमें उसका वॉल्यूम है, वॉल्यूम
एक बार शेयर कीजिए सर स्क्रीन।
ठीक है, अभी शेयर करता हूँ क्योंकि मेरा वीडियो का वॉल्यूम तो मेरे को ऑडिबल है। अच्छा, ओके, शेयर स्क्रीन।
रोहित जी, डॉक्टर नवीन और डॉक्टर अनिल को पैनलिस्ट में इंक्लूड कर दीजिए प्लीज।
हाँ, अभी देखिए इसको चला के देखते हैं।
सर स्क्रीन शेयर कर दें, नीचे शेयर कंप्यूटर साउंड आता है सर।
अच्छा,
तो प्रवीण वैसे ही चलने दो, कोई बात नहीं।
सर आप वॉइस ओवर कर ले सकते हैं।
अच्छा, वॉइस ओवर कर दे।
हाँ जी।
अभी you all are can see ना?
या
ठीक है। So what we are going to show you in this entire procedure is, yeah. Let me.
Sir, you can voice over, sir.
So you're doing bag and mask ventilation here.
Lani sir, आप voice over कर दें इसमें क्योंकि sound
Yeah, I can voice over on this.
Yeah.
So as a part of endotracheal intubation, one needs to do a mid-flexion position and try to do the bag mask valve ventilation. And what's very important is, as you can see, Dr. Uttam is doing this. And with every ventilation, there should be a good chest movement and there should be enough suction there. And please notice how the mask is being held. The 3 fingers underneath the chin and the C around the mask. And the fit should be tight. Here, Dr. Uttam is showing that the chest should be moving well with each breath because you can have a leak around the mask. And then also, it's important that the tube size should be calculated properly. Age in years plus 16 divided by 4 is a good formula for one to be able to know which endotracheal tube size is needed. As you can see by the side of the patient, there's an endotracheal tube. Now, many of the people likes to use stylet, but you don't have to. If you get good experience at intubation, you should be able to, without stylet also, be able to intubate. And during all this time, one needs to have a good pulse oximetry saturation, and someone should be talking about the heart rate, the saturation, and as you can see, Dr. Uttam is putting a laryngoscope from the left side of the mouth. He's just sort of drawing the tongue to the left side. And he's going to visualize the vocal cords. So the laryngoscopic tip gets into the vallecula. But in newborns, because the epiglottis is floppy, you may have to actually raise the epiglottis. But please always put the tube when you are adequately visualizing it. So as soon as the tube is in, what one needs to do is to connect it back to the circuit and then look at the chest movement. Somebody needs to auscultate the chest both sides for equal breath sounds, as well as nowadays we have end-tidal CO2 available to us, that if the end-tidal CO2 is 30 to 40, that means you're pretty much intubated. If the tube gets placed in the esophagus, your end-tidal CO2 will be 0. So now the pointing that I'm doing in this is that person who intubates has to hold the tube, because that person cannot give up holding the tube, because tube can come out very easily. It can get displaced, go into the right main stem bronchus. So then next step is the securing. And in general, the mark at which the tube needs to be taped is about 9 centimeter to 12. But in newborn, we talk about 1 kilo, 2 kilo, 3 kilo, and that can be 7, 8, 9. So something like that, but there are various formulas that are used. But bottom line is that it should be placed in mid-trachea, and there should be equal breath sounds, and it should be well secured. And since our purpose for this workshop is not only intubation, we'll be going further into this to talk about initiation of the ventilation. And not all the people have this C circuit available to them. So please understand that you can use the regular ambu bag to be able to ventilate the patient until you connect to the ventilator. Now, in general, we try to use uncuffed tubes, but just understand that if the lungs are very stiff, if the patient has pneumonia, you will need a cuff tube. And the lowest size of the cuff tube we have available is even 2.5. Okay, so, but in general, in pediatrics, you don't need a cuff tube until unless the compliance of the lungs is very low. So moving right along, we will just talk about what are the kinds of conditions where you are going to consider intubation and ventilation. Now, this is a slide that I borrowed from PALS. Look at how this child is gasping. You know, this obviously is too late. Okay, it's very, very important that we try to catch the children early. So listen to this one. Are you able to get the sound of this? So this is a child with stridor. This is the one. These are, very, very common things that you see. A child in moderate to severe respiratory distress, not interested in anything, feeding or anything despite oxygen. So these are the children who need to be monitored very closely. And what you want to do is to not let them get into this kind of a position where it's getting completely unconscious child who's in late respiratory failure and will then start having gasping. So this is the child who needs intubation. So main causes of respiratory failure: cardiopulmonary dysfunction, CNS, breathing control issues, and increased metabolism not matching the capacity, out of which most common indication is cardiopulmonary dysfunction. But CNS is also equally important when you're not maintaining the airway, or you have raised ICP, or you have muscle weakness, which requires support of the ventilation, even with the normal lungs. And then septic shock. This is the typical where everybody says, sir, why do I need to ventilate the patient with septic shock? Because there is increased metabolic demand that is not matching the capacity. And to take away the work of breathing, where the cardiac output is going, the oxygen demand of the body is high. So that's why controlling one factor of lungs, ventilation, helps the cardiopulmonary status. And as you all know, when you have a low output syndrome, when you put somebody on the ventilator, it does reduce the left ventricular afterload. So many times the congestive heart failure patient who you ventilate starts improving the cardiac output, especially patients with myocarditis. So I think it's important to understand this. And now this basic physiology, and I think this is very important for all to understand. Alveoli are normally open for oxygen to go in and carbon dioxide to come out. Okay. Now, suppose if the lung has pneumonia or if there is collapse. During that time, the oxygen exchange doesn't happen at the collapsed alveoli. CO2 can still come out, but collapsed alveoli will not take part in oxygenation. And that's why then you have to give some amount of pressure to open that collapse or some amount of pressure to push oxygen across through the alveoli. So now we come to this particular issue about what is mechanical ventilation. Ventilation technically means carbon dioxide to be removed from the lungs. And how does the carbon dioxide get removed? It's equal to metabolic production and then alveolar minute ventilation. That means how fast are you excreting CO2 and how much are you producing? So the normal metabolic production divided by alveolar minute ventilation, which is respiratory rate and tidal volume. So it's all about this machine, which is a ventilator, which is giving you tidal volume to go into the lungs and take away the CO2. Now, in that part, how does the oxygenation happen? Oxygenation, as a principle of physics, happens just by partial pressure. If you are giving a good partial pressure of oxygen in the alveoli, which means that is determined by the mean airway pressure. And what are the things that determine mean airway pressure? The peak inspiratory pressure, positive end expiratory pressure, and the duration for which you are giving the inspiratory pressure, and of course the FiO2 that you're adding to it. So atmospheric pressure FiO2 is only 20% oxygen. Okay, so you not only have to increase the oxygen, but also give the oxygen under pressure. Whether you give it non-invasively or invasively is a separate story. We will talk about that also. Okay, so this curve, I think, is very, very important for everyone to understand that when you see the top of this is the peak inspiratory pressure. Bottom here is positive end expiratory pressure. And if you look at the area under this entire curve is what will determine the oxygenation. So if the area under the curve can be increased by how? Increase the inspiratory time. You can increase the peak inspiratory pressure, and you can also increase the PEEP, this entire bottom area where you don't let it come down to zero. You can give 5 or 6 PEEP, and then PEEP titration can be done based on how bad the lungs are. So now, when do you initiate mechanical ventilation? When a child is having significantly increased work of breathing, and that too with maximum treatment, or can maintain marginally normal blood gases, but only at the expense of increased work of breathing. So the big issue comes up, is really a blood gas always necessary? No. Answer is categorically no. If you have a blood gas and blood gas is showing respiratory acidosis, yes, it helps you make that decision. But before that, look at the patient. If the patient is distressed, patient is having CO2 retention, patient is having tachycardia, nasal flaring, accessory muscles of breathing working, some kind of support needs to be given. You can do NIV, always try that first, or go for intubation. Okay. So what is the terminology that we use? Now, in airway pressures, peak inspiratory pressure is the maximum pressure that you will generate in any cycle. And believe it or not, whenever we go with neonatal ventilation versus NIV versus HFNC, all these terminologies will get applied in those technologies as other speakers take it up. So I'm just making this basic terminology for all of you to understand. Positive end expiratory pressure is a positive pressure that is given at the end of expiration, which prevents the alveoli from collapsing or de-recruiting. So continue to maintain the recruitment is why we give positive end expiratory pressure, and it helps in maintaining the mean airway pressure, and therefore oxygenation continues. pressure above PEEP, which is called delta P. This is a terminology used in many of the ventilators where it is the difference between the peak inspiratory pressure and positive end expiratory pressure, which means it's the delta P which is moving the volume. Okay, so in a pressure controlled ventilation, how do you say is the patient moving good volume or not? If the delta P is good, the volume is good. But now the ventilators have integrated circuits. They measure the tidal volume. So if you're giving pressure, they measure the volume. If you're giving tidal volume, they measure the pressure. And then mean airway pressure or MAP. And MAP is not to be confused with mean arterial pressure because there's a lot of overlap in these terminology, but MAP is traditionally used as a mean airway pressure. And then continuous positive airway pressure, the CPAP terminology is used. And CPAP is essentially in principle same as PEEP. It's just that the pressure being applied throughout inspiration and expiration. So a spontaneously breathing patient who's having PEEP is on CPAP. And then comes I time. I time is the inspiratory time, or some ventilators will show I to E ratio. And F is frequency or the rate, and then the tidal volume, which is the amount of the gas delivered with each breath. So having known this basic terminology, I think you can apply it to all ventilators, whether it's a neonatal ventilator or a pediatric or adult ventilator. So now I come to one basic thing, which is a terminology in terms of modes. When we say there are three basic modes, that means one is controlled mode. You can have patient completely sedated, muscle relaxed, not breathing. Machine is doing 100% of the work. That is called controlled mechanical ventilation or controlled mandatory ventilation. Then there is an intermediate mode, which is called assist control. Assist control mode is where it senses the inspiratory effort of the patient and gives a breath. So if the patient is breathing 100 times a minute, it will give you 100 supported breaths. So that's the disadvantage of it. And that's why people have now come up with synchronized intermittent mandatory ventilation, SIMV, which also senses the patient's effort, but gives you a guaranteed SIMV rate. So this issue we can discuss further as we go along. So there are basic three modes. And then other parallel thing that always comes up is, sir, am I going to ventilate this patient with pressure limit or volume limit? So whenever a breath is supported by the ventilator, regardless of the mode, volume limited or pressure limited, it essentially means that if it is volume limited, that means suppose you have set the patient on 8 ml per kg or 6 ml per kg tidal volume. After the ventilator has delivered that tidal volume, the ventilator will turn into expiration. Pressure limited mode, once that preset peak pressure has been achieved, the ventilator will go back into the expiratory mode. So essentially, when you say, are you doing volume cycling or pressure cycling? Cycling only means what changes, what factor changes from inspiration to expiration. So it could be time cycling also. Once the inspiratory time has elapsed, the patient will get into expiratory mode. So please understand, limit is separate from cycling. Limit is what is the highest limit that you have set of a particular parameter above which ventilator will not go. So sometimes we have to go higher than that in many of the patients with stiff lungs and take the risk of barotrauma. So what we are trying to do is ventilators have a pressure limit or volume limit. And now let's talk a little bit more about cycling. Volume cycling, when the preset tidal volume has been achieved. Pressure cycling, when the preset peak inspiratory pressure has been achieved. And time cycling, when set inspiratory time is achieved. So the goal is to ventilate and oxygenate adequately with least barotrauma, least volutrauma. That is where all these terminologies you've started hearing: permissive hypercapnia, permissive hypoxemia. But important basic requirement. It's a big machine, and here is the patient. If it is not moving the chest, something is wrong. Please make sure tube is open, tube is not migrated, tube is in trachea, it's not obstructed. And so bottom line is it must move the chest and you should hear the breath sounds. Okay. Now, ventilators have been having built-in high, low pressure alarms just to make sure that you don't exceed those limits. So what is the advantage of pressure limited mode? It compensates for the leak around the endotracheal tube, and it will achieve whatever volume it takes to achieve that pressure that you have set. The problem is when the lungs begin to improve or get less stiff, like for example, a patient with hyaline membrane disease, newborn, whose lungs, once they start improving, you can cause pneumothorax given the same pressure because the lung compliance is better. Okay. And volume limited mode, what is the advantage? Ventilator will deliver the set volume regardless. Okay, so it is a guaranteed volume, but problem with that is that it can achieve too high pressure, and if there is a leak around the endotracheal tube, you will lose a lot of tidal volume. So I think it's a balance that one has to keep. So stiff lungs, better to use volume control and a cuff tube. Okay, so if the volume is set, pressure varies. If the pressure is set, volume varies, and according to the compliance. So either way, chest must rise. So now one terminology that is also needs to be understood is called trigger. Trigger is the factor which could be a pressure or a flow that determines initiation of inspiration by the ventilator. Okay, so patient's effort can be sensed by the change in pressure, like a negative pressure, or the flow can change during that time, and ventilator senses it and then gives you a breath cycles. So one terminology that I think is important for all to understand is that it's called pressure support. Pressure support is separate from CPAP. Ventilator provides simply a flow during inspiration to achieve a certain peak pressure for patient trigger breath for the duration of inspiration that is determined by the patient. So it's important that when you give flow from the ventilator is not cycling. Let's say you're just giving the flow and the patient is having an inspiratory effort. During the duration of inspiratory effort, the ventilator simply provides that flow, and that's called pressure support. This can be applied in a patient who is supported by set SIMV rate during the spontaneous breathing, or it is also used as a weaning mode in patients who are being weaned. You are weaning them with SIMV and you cut down the SIMV rate, and then you put them on the pressure support so that the patient is not breathing against a vacuum, is getting some amount of pressure. And then CPAP, as we talked about, it's about same as PEEP, which is a small amount of volume that is always in the alveoli, and it generates some amount of PEEP. So physiological PEEP is about 3 to 4. So whenever you put somebody on the ventilator, you should make sure at least you are giving physiological PEEP. But because these indications are pneumonia and other things, so usually 5 or 6 PEEP is good enough starting point. Okay. So then now, because of this confusion of whether I should put somebody on pressure control or volume control, ventilator research group came up with this mode called pressure regulated volume control, which means you can give a particular volume with minimum pressure throughout the ventilatory cycle. Essentially, that's what it means. So one cannot classify it whether it's a pressure or volume mode. It's a hybrid mode. It's a hybrid mode where the pressure regulated volume control is given and delivers the breath with a decelerating flow pattern, which is thought to be less injurious to the lungs. Okay, so now if you look at the waveforms, this upper waveform is the flow, this middle waveform is pressure, this lower waveform is volume. So in a control mode, it's going to give a volume preset ventilation, and here the pressure and peak flow and the volume, all of these will be dependent upon the compliance and the resistance of the system. So let's moving right along. This little trigger that you see tells you that you are in an assisted mode. That means with each negative pressure flicker that is happening, the machine senses it, and gives you a trigger. Okay, so this trigger is generated by the patient, and machine gives you the breaths equal to the patient's breathing, spontaneous breathing rate, which could be very shallow breaths. Okay, so now we come to this further one that I talked to you about, SIMV. How does SIMV look? SIMV is synchronized intermittent mandatory ventilation. Okay, here is this patient's negative effort. You see this? And then in between here in the green area is the patient's spontaneous breaths. And you can see the flow is not good, pressure is not that good, volume is less. So this patient is essentially getting good support by the synchronized ventilatory breaths. So if you look at the flow diagram, flow scalar, Dr. Rachna will be showing more of these so that you understand how to recognize a patient who's on SIMV volume control. So then we come to the initial settings. Choose the mode first. Okay, so if the patient is completely sedated, muscle relaxed, you have to choose controlled mechanical ventilation. Never put the patient on assist control mode if the patient is completely muscle relaxed and sedated. I mean, that's a basis of it. But having said that, most of the patients we are able to get away without using muscle relaxation. With just some sedation, once the tube is secured, you should be able to use SIMV or assist control mode, and where the patient's spontaneous breathing is also allowed, as long as the patient is not fighting the ventilator. So that means the patient who's breathing at 80 times a minute, you put him on a SIMV of 20 good breaths, that patient's spontaneous respiration will also slow down to about 50, 60, will be more comfortable. Then you can give some more sedation, and then you are able to, without muscle relaxation, be able to initiate the ventilation. So what are the settings that you will do? Regardless of the ventilator, when you have chosen, let's say, pressure limited mode, you want to choose FiO2, rate, inspiratory time, and peak inspiratory pressure, and positive end expiratory pressure. When you are on a volume limited mode, you have the same 5 parameters, except instead of PIP, which is determining volume in the pressure limited mode, you choose tidal volume. But you know, this is semantics. If you have chosen tidal volume, the ventilator is smart. It will give you what is the peak pressure it is achieving to deliver that tidal volume. So therefore, you can always have some numbers like plateau pressure should not go more than 30, because if it goes more than 30, you are going to injure the lungs. And if the expired tidal volume is less than 6 ml per kg, you probably have some leak in the circuit. You may have to increase the inspired tidal volume. So those are the fine tunings. But basic mode, any ventilator will give you FiO2, rate, inspiratory time, PIP, and PEEP. Okay, so how do you choose the initial ventilator setting? So let's say start with a rate that is somewhat normal for that age. 15 for adolescent, like almost like an adult rate, 20 to 30 for infant, and 40 to 50 for newborn. So newborn, traditionally they say, you know, you are able to give 50, 60 to the newborn, not a problem. FiO2, you can always start 100% and then wean down quickly. That means I'm not saying that you put somebody on 100%, because 100% is toxic. So when you don't know how bad the lung disease is, it's always a good idea to start with 100% and quickly wean down to the lowest oxygen that will achieve you saturation of 93, 92, and that's good. Physiological PEEP, 3 to 5. Inspiratory time, I/E ratio. Okay, so what does the monitoring panel display to you? There's an oxygen concentration, it shows all the time. Total respiratory rate, it shows you. Peak inspiratory pressure, it shows you. Plateau pressure also it shows you, which is sort of a mean of that around the peak, and it comes down a little bit. So a mean pressure throughout the inspiratory cycle. On the peak side is plateau pressure, but it's not the bottom. It's like after the peak, just a little spike, you see that plateau pressure. Then mean airway pressure, and then expired tidal volume. So basic thing is, how would you affect oxygenation. So you have a patient who was intubated for hypoxemia. How will you fine tune the settings further after you have chosen the tidal volume and the rate and FiO2? To affect oxygenation, just remember FiO2, PEEP, inspiratory time, and PIP, positive, peak inspiratory pressure. And to affect ventilation, simply adjust the rate and tidal volume, because rate and tidal volume product is called minute ventilation. Okay, so to affect ventilation, if your minute ventilation is good, you will be washing out more CO2. That means if the respiratory rate is low, you increase the respiratory rate. If the tidal volume is low and the CO2 is high, then you increase the tidal volume. But usually tidal volume, there is only a certain limit that you can do, like maximum 8 ml per kg, but generally recommended is 6 ml per kg. Okay, so if there is inadequate oxygenation, don't just increase FiO2, increase the tidal volume if the patient is on volume cycling, as I said, within that limit, or increase the peak inspiratory pressure and then monitor how much is the expired tidal volume. Because expired tidal volume, which is really coming back to the machine after taking care of the leak and circuit expansion and all that, is a reasonably good parameter for you to know how much are you delivering to the alveoli. Now, if oxygenation is worse, do get a chest X-ray. Make sure that there is no air leak or there is no worsening of lungs like bilateral whiteout or more fluid in the lungs. And do not forget other measures. This is very important. Ventilator alone is not going to make the patient better. If the cardiac output is low, one may need to give inotropes, may need to increase the fluids if you are already dehydrated, maintain normal hemoglobin because you need a good oxygen capacity, and maintain normothermia, then deepen sedation. Once you have seen, all of these things are within normal limits. Now, suppose somebody is having high PCO2. The reasons are dead space ventilation, or if you have increased CO2 production, like in hyperthermia, high carbohydrate diet, septic patient, inadequate tidal volume delivery, tube block, malposition, all those things need to be checked. But once you have checked that, you simply try to increase the minute ventilation, which means increase the rate and decrease the, increase the rate and also the tidal volume, so that you are able to wash out the CO2. This principle changes in high frequency, and which I think Dr. Ankur is going to address that because it's the other way around in high frequency, because the physiology works a little bit differently. So now measures for high PCO2 accordingly improve the minute ventilation. And then if you are having a blocked, kink tube, malplaced tube, please make sure that you change the tube. These mechanical factors itself can cause a lot of problems and fix the leaks in the circuit and cuff and humidifier. So if patient fights the ventilator, this is the most common question that comes up. So this patient is fighting the ventilator, so what should we be doing? Must rule out hypoxemia. In a struggling patient, the patient struggles because of that. One is, of course, you have put in the tube down the throat. That patient needs to be properly sedated. But before you deepen the sedation, please make sure that the tube is inside, in the trachea. And then only you can manipulate all the oxygenation pressures to be able to improve the oxygenation. So in sepsis, due to increased oxygen demand, increased CO2 production, patient can get restless. If the tube is blocked, big mucus plug, kink, malposition, or simply bronchospasm, this patient is in need of bronchodilator therapy. That itself will do it. And then never miss pneumothorax. And nowadays, we are all sort of learning that we should learn to do the probes, ultrasound, and you are many times, without even waiting for the X-ray, are able to determine pneumothorax, increase fluid, and so lung ultrasound is, I think, is a good thing that people should try to learn. But otherwise, you have to wait for the X-ray. But as a principle, tension pneumothorax, you have to needle the chest. There is just no other way. You cannot wait for the X-ray. So make sure mnemonic dope is applied: displacement, obstruction, pneumothorax, and look at the equipment failure. So immediate what measures will you take? Take away the ventilator and start doing manual ventilation with 100% oxygen. Examine the patient, treat bronchospasm, look at all the dope things, ensure that the tube is well placed. When in doubt, take it out. If you are in doubt of endotracheal tube, whether it's in or not, take it out and put a new tube. Check ABG, chest X-ray, common correctable causes of hypoxemia. Once they are ruled out, you can increase the sedation. So because ventilator is associated with increased ventilator-induced lung injury, one has to do gentle ventilation. And that's the reason why we talk about accept a little bit higher PCO2 as long as pH is 7.25. Some of the faculty even talks about 7.20 is okay also. But I think below that, the cellular metabolic function starts getting affected. So too low of a pH is not good. But a little bit high PCO2 can be accepted. Otherwise, you have to give a lot of high pressure and volume. Permissive hypoxemia, same way. Accept the PO2 of 55 to 60, saturation 88 to 90 in a patient with stiff lungs, and try to limit the FiO2 to 0.6 so that there is no acidosis. So that's what's most important. And we do PEEP titration and maintain the oxygen content. So one condition where you don't allow permissive hypercapnia, two conditions actually. If you have a PPHN, hypercapnia is not good for pulmonary hypertension. And when there is increased intracranial tension, high ICP, then also you don't allow that. Okay, so the other complications also one has to understand that when there is an increased thoracic pressure, your cardiac output can go down. So it should not be too high of a intrathoracic pressure. And some effect then of a high ventilatory setting can be decreased cardiac output. So must ensure that you have enough volume in the system and you give enough inotropes. Other complications like ventilator-associated pneumonia, ventilator-associated events. So each and every single day of additional ventilation puts you at risk. So therefore, try to think about when to extubate from day one. You know, whatever is the necessary thing that's needed, patient has to be given. But once conditions start getting better, X-rays getting better, secretions less, and all those things, normal gases, you should start active weaning. So what is the prerequisite for weaning? Is the cause of respiratory failure gone or getting better? Is the patient well oxygenated and ventilated? Can the heart tolerate the increased work of breathing? And is the patient too sedated? Now, please mark these things because Dr. Anil Batra will go over these in detail. Is the muscle power good? Is the patient fluid overloaded? Does the patient have sodium, potassium, calcium, magnesium normal? Is the patient hypothermic? All of these small little things will add up and can cause weaning failure. So I think it's very, very important that all these details are taken care of before you consider getting into extubation. So how do you wean? Decrease the FiO2, decrease PEEP, decrease the rate, and there are no formulas for that. You can do 10, 20%, 10, 20% down, then monitor and see how to, because no algorithm will give you a perfect thing. Most children tolerate any of the weaning protocols and are able to successfully extubate once their disease is better. So what you want to do is to decrease what ventilator does and see if the patient can make up the difference. So let's say you have reduced the SIMV rate and patient starts having nasal flaring and is getting tachycardic and is anxious. Probably not good idea at that time. Maybe the lung disease is severe and all that, but every day is different. So the patient may show you a success. Before extubation, one must make sure that you are ready for extubation. It's called extubation readiness check. Control of airway reflexes, awake patient, upper airway reflexes, minimal oxygen requirement, minimal rate, minimal pressure support, and one can give SBT, what is called spontaneous breathing trial, which you can give on C-circuit or even T-tube to just see. Once you have done that for about 15 minutes is the minimum, but some people like to give it for 30 minutes. And you give 30 minutes spontaneous breathing trial that can be given through the ventilator also, that you put the rate to 0 and you are just giving flow and see how the patient tolerates, and then you are able to extubate. So in summary, what I've shown you is essentially why you would ventilate and how to manipulate these physiological parameters during ventilation. Both pressure versus volume cycling ventilation can be used for good monitoring, low tidal volume strategy. And if there is sudden emergency, bradycardia, cyanosis, use manual ventilation, make sure you check the tube, change the endotracheal tube, look for and treat pneumothorax. Once hypoxemia is treated, only then sedated must relax. So continue to wean to minimal settings to have an acceptable clinical parameters. And you don't still have to have a normal blood gas before you extubate. Improving blood gases are enough. The trends are enough. End-tidal CO2s can be monitored. And many of these things now we do non-invasively. So thank you very much for patient listening. Yeah, Dr. Manish, you can hear me? Namaskar, Dr. Nav. Please unmute. Please unmute. Unmute yourself.
Dr. Nav, I welcome you all for this webinar on digital platform. And it's a beautiful workshop which you have conducting. I'm grateful to Dr. Praveen Khilnani for this initiative. And the entire team is very accomplished and esteemed faculty. So we are, all the delegates are going to benefit with this. I'm grateful to you all. Thank you.
Thank you. Thank you, Dr. Nav.
I would just like to announce, sir, the workshop is full. 100 people are fully listening, and there are a lot of queries to launch it at YouTube and Facebook, and we have made it available at Facebook Live, sir.
Facebook and
Congratulations to all the team, sir.
Thank you. Thank you. Thank you very much. I think moving right along in the interest of time, what we will do is at the after these talks, we are going to have a good interactive session with all the panelists. And because there are neonatal questions, there are basic questions, there are pediatric specific questions, intubated related, I think we should just sort of keep it open for quite some time in the valedictory session where we can have all the question answers. So for now, we'll just move right along to, let me just see if my stop share. Okay. Our next speaker is Naveen, Naveen. Yeah.
Naveen, sir.
So our next speaker for this evening is Dr. Naveen Gupta. He's a very esteemed neonatologist and is currently has worked at many hospitals, Max Hospital also. He's been at Rainbow Children's Hospital as in charge of the neonatology. He was trained in Vancouver Children's Hospital, BC, and also has done DNB in neonatology from Gangaram Hospital. So is very well familiar with the Western Indian concepts, nitric oxides and, high frequency and how it applies to the advanced neonatology. So his, I'd let him start with the neonatal ventilatory concepts. So Dr. Naveen, kindly share, do the slide share. Yeah, all yours.
Sir, are my slides visible, sir, right now?
Yeah, it is. Yeah.
Yeah.
Okay. Thank you, sir. Thank you for the nice introduction. And I want to thank the whole PCNI organizing team for giving us an opportunity to be a part of this workshop with all the esteemed panelists. So in the next half an hour or so, I'm going to take us to the journey of the non-invasive to invasive ventilation. So because in the whole workshop is on ventilation and invasive ventilation will be talked too often. So I will be focusing mainly on the non-invasive ventilation. So why should we go for non-invasive ventilation? There was an era in which the baby is having distress and we used to intubate the baby. But people tend to think about it that like intubation has got its own problems. Like intubation generates a lot of inflammation, mucus plugging starts in, eventually the child starts getting X-ray shadows. For newborns, when we look that even with the gentler ventilation also, we were not able to bring down the incidence of the bronchopulmonary dysplasia in the premature babies. And there were many retrospective data which suggest that if we can avoid intubation, it can lead to decreased bronchopulmonary dysplasia. So there is a rationale for non-invasive ventilation. What all options do we have and which one to use when? We will try to see that how it goes. So let's start with a very common scenario in which a late preterm 35 weeks is born through the elective C-section. Baby cried immediately after birth. Baby received mother received steroids initially, and there was no history of leaking per vaginum. Delayed cord clamping was done. Baby was shifted to NICU. Why? Because the baby started having breathing difficulty in the delivery room. Now, this is how the baby is having respiratory distress. So first we need to do is we should quantify this respiratory distress with the help of the either Downey score or the Silverman-Anderson score. You can hear the grunting also in between. So purpose of quantifying that is that we will come to know that how this distress is going. Is it increasing or is it decreasing? So in your NICU, you should have, like the nurse should have the component of the Downey score, so that every hourly or every 2 hourly she can plot. By that, we will come to know also that when we start the intervention, does the Downey score comes down to normal. So what are the options we have when we have a late preterm such kind of the baby? We immediately put the baby on oxygen, we start the baby on non-invasive ventilation, or we ventilate the baby. So the best option here will be to start the baby on CPAP. Why? I explain you. Suppose you put such kind of baby to oxygen, maybe his oxygen levels will be normal, his saturations will be better, but we are not trying to correct the underlying cause why this baby is having breathing difficulty. Normally a 35-weeker born through elective C-section will have breathing difficulty when the lungs are wet, when the excessive fluid hasn't been gone from the lung, or sometimes there is an element of prematurity also and the surfactant is deficient. So in both the scenarios, CPAP by opening the lung, by recruiting more alveoli, will facilitate the gas exchange and will help the child. So initially this baby was put on oxygen through the hood when we were planning to put the baby on oxygen. So you can see that when the baby is on oxygen, then his saturations are good, but his respiratory distress is persisting. So, and when we put the baby on CPAP, his work of breathing is definitely lessened. So CPAP is why non-invasive support, because eventually for treatment of any problem which is leading to RDS, be it the HMD, be it the transient tachypnea, be it the pneumonia, be it the baby who is coming with sepsis. So airway distending pressure to maintain FRC. So this FRC is a fancy term. What does it mean? Functional residual capacity. So that means that air which is remained in the lung after a normal tidal expiration. How do we judge or assess the FRC? It is by looking at the X-ray. Some people go by counting the posterior end of the ribs which are attached to the spine. Some people count the anterior end. Posterior end, we say that 7 to 9. When the diaphragm is at the level of 7 to 9 ribs, it's okay. Anterior end, when we are counting, we say 4 to 6. So this is an indirect parameter. But so FRC maintaining is good. So if FRC is maintained, that means alveoli, they are recruited well. That means even at the end of the expiration, the alveoli are taking part in the gas exchange and baby is breathing comfortably. So any non-invasive support by providing PEEP, which Dr. Khilnani in the previous talk tried to tell about. So PEEP is the positive end expiratory pressure. So this is the pressure which remains throughout the respiration, be it the inspiration or expiration. Don't go by the name that it is just the positive end expiratory pressure, meaning that even when the expiration ends, then also this pressure is there. So this is the baseline pressure. So any non-invasive support by providing this PEEP, it tries to maintain the FRC and tries to take away the work of breathing. So eventually less chronic lung disease, when we are not intubating the airway, when we are not fiddling with the airway, then the baby likes it more and there will be fewer complications, fewer infections, reduced inflammation and stress for the babies, for the families also, for the staff also. For ventilated baby, we will be providing 1:1 staff. For family, the baby goes on ventilator and they are going to talk to you more and more. And the cost is also an issue. So when to use? Normally, when we talk about neonatology, there are 3 scenarios. First scenario is when on day 1 of life, your baby is having respiratory distress. If your baby is very premature, we understand that this is because of so much reduced surfactant and the lungs are very wet and the lungs are very small. So start delivery room CPAP only. With the first breath only, you put the baby on the CPAP. So for that, you should have a T-piece resuscitator in the delivery room. The second subset of the baby is slightly they are also premature, but it's between 28 to 34 weeks where you see that as the gestation advances, the incidence of the RDS decreases, but it is still there. Like at 34 weeks, we say 20-25% of the babies will have breathing difficulty. So as soon as the baby starts having breathing difficulty, put him on CPAP. More than 34 weeks, when the late preterm and term babies, when we understand that there is a component of TTN also, and in 60-70% of these babies, sometime when we wait, the respiratory distress disappears after 6 hours, and you can shift the baby to the mother. So in those babies, we can wait for 4 to 6 hours. And if after 4 to 6 hours, the distress persists, you give CPAP, or before that, if the baby started falling up to maintain saturations also, you can start CPAP. In the post-extubation phase, when you have a baby who is ventilated, you wean down on the ventilator, you extubate the baby. There was a time when these babies were extubated to oxygen, but there have been Cochrane review also which suggests that whether we extubate the baby to oxygen with CPAP, extubating them to non-invasive support, whether it's CPAP or high flow, is better. It leads to lesser chances of re-intubation. And in premature babies, when they have apnea of prematurity, mostly the obstructive apnea as well as the central apnea, where the CPAP or the non-invasive ventilation, it splints the airway and it helps in decreasing the incidence of apnea of prematurity and decreasing, not decreasing the incidence, but decreasing the rate of intubation in such kids. So these are primarily 3 situations which stands. So how can we give NIV? So now there are different modes. There was a time when CPAP is the gold standard, when in 1973, Dr. Gregory discovered it, and the CPAP was all across the board. But there were certain problems with the CPAP. So over the past 5 to 10 years, the heated, humidified, high-flow nasal cannula has come across in a large settings, and even without the RCTs, there was approximately 65 to 80% of the units, the Western units which were using high flow for various indications in the various surveys which have been done. Nasal IPPV, yes, it also has got a place, although the synchronized nasal IPPV, which is not so readily available in our country, has got a better place as compared to the non-synchronized IPPV. The SIPPV is the synchronized IPPV. Nasal high frequency ventilation, I don't think so that this is the time when we should be discussing, and very frankly, we are not even using it. So I discussed about the physiologic rationale of CPAP. Mainly, it is the distending pressure which recruits the alveoli. Recruiting alveoli means that alveoli are taking part in the gas exchange. And if alveoli are taking part in the gas exchange and they remained open at the end of expiration also, so the baby can breathe comfortably and baby will put in less effort for the next breath. It increases, stabilizes FRC. FRC we discussed. It definitely splints the upper airway and compliant chest wall in a premature baby, thereby decreasing the apneas of prematurity. It improves lung compliance. It reduces airway resistance, so baby can breathe in comfortably. Eventually decreases the work of breathing, and by recruiting more and more alveoli, it improves the gas exchange and reduces apnea. Is there evidence for it? Yes. If we take off these studies, approximately 3,000 babies have been enrolled. These studies have been done in 25 to 28 weeks babies. Outcome is BPD here, and the comparison is between the CPAP versus control is if the babies are intubated in the delivery room. So you can see that when you combine it, the CPAP, the relative risk is 8% less for the bronchopulmonary dysplasia. So if you don't ventilate these premature babies, so this study I am again saying that they have been done in 25 to 28 weeks baby. So if you don't ventilate, it's hard to cause BPD. So what are all the CPAP devices we have? We can provide CPAP through the ventilator, right? So in the same circuit, when your baby is, you can intubate the baby later on also. So the interface changes basically, and through the same ventilator with which you are going to ventilate the baby, you can provide CPAP only. Bubble CPAP is an inexpensive way, so that you don't need to buy the 15 or 25 lakhs ventilator to just give the CPAP to the baby. There is a kind which is called variable flow CPAP also. These are the flow drivers which were once very, very fashionable and once very much in the use. But then there have been a lot of studies comparing variable flow CPAP to bubble CPAP, and variable flow CPAP does not have a major edge over bubble CPAP. So eventually, bubble CPAP is the poor man's CPAP choice. Ventilator CPAP, suppose your unit is having 10 ventilators, so you can use the ventilator CPAP also. And we will be discussing that are there differences between the ventilator CPAP and the bubble CPAP. The major thing you should know is what we are doing in CPAP is that in the expiratory pathway, we are creating a resistance. So in ventilator, in all the ventilator, there is an expiratory valve, and that expiratory valve is closed to some extent. Like suppose I have put a CPAP of or PWP of 5, then the expiratory valve is closed to some extent. If I have put a PWP of 8, then the expiratory valve is more closed. When it is more closed, then the airway resistance increases, and eventually that translates into the positive end expiratory pressure, and the alveoli remains open up. Think of that why in RDS baby grunt. What is grunting? Grunting is when the baby is forcefully expiring against a partially closed glottis. So what is baby doing? In his expiratory pathway, he is partially closing the glottis, thereby increasing the resistance. Thereby the baby is trying to create the PWP. And when we are putting the baby on CPAP, we are trying to replicate the same thing in the circuit. How does we increase the airway resistance in the bubble CPAP? In the bubble CPAP, the PEEP is generated by the immersion of the expiratory limb in the bubbling chamber. So when we put, suppose to 5 centimeter, we dip that limb in the bubbling chamber, 5 centimeter pressure is being generated. So let's see bubble CPAP setup. Suppose somebody is working in a level 2 setup, or there are many pediatricians. When you are taking care of the newborns, you want to set up this thing. What all do you need? So first is you need to have a compressed oxygen and air source. So either you can have a unit like in your hospital, there is a separate place where you keep the air and oxygen, and in your NICU and PICU you have a supply, or you can use the cylinders in your NICU and PICU. This setup is, it's not so expensive, so you can, your air and oxygen source should be separate from the NICU and PICU. So this is the first thing. And secondly, keep one message before this presentation to take away from this presentation is never give CPAP with 100% oxygen. So you should have a blender which blends both the air and oxygen so that you can give the desired oxygen to the baby. Over the years, we have recognized that giving high amount of oxygen, it's a potential pro-oxidant, and giving high amount of oxygen can be dangerous to the premature baby and the term baby. So never give CPAP without blender, or if you don't have blender, I will show you the option that how we can mix both air and oxygen, but you should have an air and oxygen supply. The third thing is this air and oxygen which is coming from the cylinders. In cylinders, we compress the gas. For compressing the gas, we need to bring down the temperature in the minus. So that's why the gas, when it is coming from the air cylinder, it is very cold and it is very dry. Now the same cold and dry air or oxygen mixture, if it goes to the baby, it will damage the cilia. It will lead to increased secretions and the baby, so it can lead to increased incidence of pneumonia. So that air should be warmed and humidified so that it doesn't harm the child. So for doing that thing, we should have a humidifier. So and the humidifier temperature should be somewhere around 37 degrees Celsius. So the third step will be you should have a humidifier. And the fourth is when it goes to the baby, there should be an interface. We will be discussing interfaces. It can be in the form of mask. It can be in the form of cannula. It can be in the form of, there was a time when endotracheal tube was used in the one end for a nasopharyngeal CPAP. So things like that. And then the expiratory limb is going into this white one. So nowadays, the many circuits, they are color coded. The blue one is inspiratory, white is the expiratory. From the baby, this expiratory is coming and it is going into the bubbling chamber. And in this bubbling chamber, the depth to which we insert, that becomes the CPAP or the PEEP. What if you don't have a blender? Don't worry, blender is an expensive device, but this Y piece, this connector you can all buy. There is an oxygen, there is an air. So air and oxygen, they are coming and you can adjust the flow rate you can keep this chart inside your NICU. You understand that if you are giving suppose 2 liters of air and 2 liters of oxygen, how much FiO2 is giving. And otherwise you can calculate this with a simple formula also, where you are accounting 21% of oxygen in the air. There are interfaces. The key message to take from here is short binasal prongs are the best, or the nasal mask are the best. If we increase the length of the prong, then we are actually increasing the resistance. So that is why short binasal prongs or the nasal mask, they are the best. The here 3, these are the heated humidified high flow nasal cannulas. This is the OptiFlow one, this is the another facial packle one, and this is the RAM cannula. So how do we know CPAP is working? You put the baby on CPAP. Why? Because your baby was having increased work of breathing. His work of breathing is gone off. He is breathing comfortably. His saturations are being maintained. That's how you know that the CPAP is working. When you put the baby on the bubble CPAP, always remember that bubbling is flow dependent. Suppose you have dipped to 5 centimeter and you feel that you are giving the 5 centimeter PEEP to the baby, but at different flow rates, different PEEP will go. This we will be discussing in the next 2 slides. So this is what we want. When you put the baby on CPAP, your baby is breathing comfortably and he is maintaining the oxygen level. You look at the monitor and the baby is saturating well. So look at the difference between the bubble CPAP and ventilator CPAP. This is a very interesting slide. On the y-axis is the pressure. Suppose you are giving 8 centimeter pressure. Okay. The blue line is for ventilator. The orange line is for bubble CPAP. Now at different flow rates in the bubble CPAP, although you have immersed the bubbling chamber to the same 8 centimeter level, at a flow rate of 4, suppose 8 pressure is going at the nasal interface. At flow rate of 6, the pressure increases. Look at the orange line. Flow rate of 8, it increases further. 10, it increases further. So if suppose high flow rates have been set and the bubbling is too much, so that can lead to increased delivery of PEEP to the baby, and that can lead to increase in pneumothorax. So bubbling should be minimum to generate the, flow should be minimum to generate the adequate bubbling. Flow should not be excessive. In ventilator driven CPAP, the pressure given is independent of the flow. Even if you increase the flow rate, if you have set a PWP of 5 or 6, whatever you have set, the same will be delivered to the nasal interface. So bubbling should always happen. It should neither be extreme, or it should neither be too much, or it should not be absent also. If suppose bubbling is not happening, what does it mean? It means that CPAP is not being delivered to the baby. You should check for leak somewhere. Majority of the time, the leak is at the level of interface. Either the prongs are not snugly fitting into the baby's nose, or the mask, at the level of mask, the leak is there. And if there is no leak, then you may need to increase flow to ensure bubbling. Let's look at certain videos. Like this much of bubbling is adequate. You look at the flow is 7 liters, and this much of bubbling is adequate. So this is adequate bubbling. You don't need to do anything. Look here, there is no bubbling is happening. Okay, so when no bubbling is happening, what you will do is, CPAP is not being delivered, you will check for leak, and you may increase flow if there is no leak. But majority of the time, you check, you take care of the leak and the bubbling starts. What is happening here? Here there is inadequate bubbling. Bubbling should be continuous both during the inspiration and expiration. If you see, sometime it is bubbling, sometime it's not bubbling. So you will increase the flow. Then look here. Here the bubbling is too much. It is excessive bubbling. So maybe your flow is too high. Some doctor has come or some nurse has inadvertently increased the flow. So you need to decrease the flow. Now in the same patient, when the flow is too much, see here even the noise is too much. So the water column is displaced too much and the flow has been set at 13 liters. So you need to decrease the flow rate, because the PWP delivered to the baby here might be too much and the baby may blow out the lungs. Pneumothorax may happen. So let's look at a small clip on putting on the nasal CPAP, but all should. So first we should ensure that we should have all these things ready. This is the nasal interface, nasal mask, then the cap should be there to hold it, and the nasal mask should be there. So these are the things you should have. First, you will take the head circumference. Once you take, and then you check for the appropriate size on the nasal mask. Once you check the head circumference, you will take out the cap of the same centimeter. Like in this baby, it was 25 centimeter was head circumference. So 22 to 25 centimeter cap was taken, and then the cap was fixed. Then the interface will be attached, but before that, the nasal portion where the mask will be placed, it is protected. It can be protected with the help of cannulates also. Here the sister is applying, the nurse is applying just the tegaderm. So somehow you need to protect it. Important thing is that in every shift, the nurse should inspect it, that there should be no injury, because masks sometimes produce indentation at the level of nasal bridge. Then this mask should be placed, then the mask should be placed, and you need to keep in mind that the interface, the foam should be in the middle of the forehead, so that it is placed in the center. Similar way, the prongs are being placed, and then with the Velcro, which was provided with the cap, these prongs are they are being then fitted. So there should be pressure which should be applied by the sister from the center of the nose, and then this is fixed. So this fixation is quite important. So once you have a bubble CPAP, you will come to know when it is fixated, when you will see a bubbling. In ventilator derived CPAP, you will see a constant pressure line over the ventilator. And then while pulling, the prong should be in the center, and you should be pulling with the both hands with the equal force, so that the mask remains in the center. And then you can check and inspect the side. And then you look for the saturations, and your baby should become comfortable. So if you keep in mind these 3 or 4 steps while fixing, yeah. So this is how then your baby looks like. Okay. So all the devices same? No, there have been studies, bubble oscillations. Some people think they may improve lung recruitment by giving high frequency type thing. Bubble CPAP pressure delivery is flow dependent. We have discussed it already, and its pressure delivery varies more than variable flow. How much pressure do you start? No fixed guideline. 5 to 6 centimeter is a good pressure. Flow 5 to 8 liter per minute is good. Target saturation should be between 91 to 94%. How do you ensure optimum PEEP? Look clinically, the baby is work of breathing is better. Look on your pulse oximeter, tachycardia will not be there, saturations are being maintained, and sometimes you can do a blood gas and there should be no acidosis in the blood gas. X-ray, look for the FRC, 7 to 9 posterior end of the ribs, diaphragm should be at the level of 4 to 6 anterior ends. Indications we discussed, apnea, RDS, and post-extubation. PEEP range 4 to 8 is considered good. More than 8, we are worried that pneumothorax may happen. Less than 4, inadequate. So your baby should be comfortable, minimal retraction, no grunt, normal capillary refill time, baby is well perfused, blood pressures are good, saturations are good, and normal blood gas. When to wean? Once your baby is stable for 12-24 hours, wean down in a pressure of, and your FiO2 need should be at least less than 30%, then only you wean down pressure. So how to wean depends on the underlying condition. First, reduce the FiO2 to 30% and then decrease pressure in the step of 1 to 2 until 4 centimeter. If your baby PEEP is 4, FiO2 is less than 30%, baby is clinically well, you can remove the CPAP. But there are certain problems with the CPAP also. What are the problems? It is discomfortable for the child. The prongs are especially discomfortable. With masks, sometimes yes, sometimes baby is comfortable, sometimes not. In premature, we understand that development supportive care is very important to improve their long-term neurodevelopmental outcome. And one of the component of development supportive care is kangaroo mother care. When the CPAP mask or prongs are there, it's not so easy to do the kangaroo mother care. The third is the nasal injury. Yeah. So with all the prongs, in spite of the prongs are being quite good, then also there is nasal injury. With mass, there is indentation at the level of nasal bridge. And many a time there is CPAP belly, that the baby's abdomen gets distended and we have to stop feeds. So what is the option we have? In the past few years, there is a contender which is called high flow nasal cannula. Subsequent 10-15 slides, we will discuss about this in the past. So high flow systems, same as CPAP, you need a compressed gas source of air oxygen, you need a blender, you need a humidifier. But the change is that for high flow, you just need an inspiratory limb. You don't need the wide expiratory limb. You don't need the bubbling chamber. So look at the system. The interface high flow, it is slightly different. And there is a blue inspiratory limb. There is no expiratory limb. There is a blender, there is a humidifier. So, and the difference between the high flow nasal prongs and the CPAP nasal prong is, basic difference is CPAP works on the distending pressure. So CPAP nasal prong should be snugly fitting the nose. There should be no leak. And in high flow, when there is no expiratory limb, they should not be snugly fitting the baby's nose. In high flow, we say that the internal, the dia of the high flow nasal prong should be 50% of the internal diameter of the nose. How does it work? Distending pressure is one of the mechanisms, but it's not the only mechanism. Mainly high flow works by gas conditioning effect. It washes out the dead space, the nasopharyngeal CO2 dead space. So wash out of the flow exiting from the mouth. Look, this is very, very important. So when you are putting the baby on high flow, always remember that there should be leak around the prongs. If there are no leak around the prong, you snugly fit the nose. You snugly fit the high flow prong into the baby nose and there is no expiratory limb. The lungs may blow out. There may be pneumothorax. So always remember this important difference. Who is using high flow? These are the surveys in 2010, 60-80% of the units they were using. And the incidents actually have evolved from 2010 to 20. Why it is being used? Easy to use. Baby is very comfortable. It is safe. Decreases work of breathing. Nurses love it. Less nasal trauma. The mothers love it. They can do kangaroo mother care. Interfaces, the middle one, which is the OptiFlow. This is nowadays, from last 4-5 years, we are using only this one because these prongs are the best. So high flow interfaces, this is the OptiFlow, this is the RAM cannula. Sometimes RAM cannula, you can even attach to the bubbling chamber and you can put the CPAP also. So where all have been tried, same condition, primary mode, post-extubation failure, apneas. So when you look for the Cochrane review, so this is the older one, but I, for the benefit of time, I'm taking away this evidence. But what I will tell you is that when high flow has been used in primary mode, CPAP is better. CPAP provides more distending pressure. Baby's lungs are more wet and they need CPAP more. In post-extubation, the CPAP and high flow, they are equivalent. There have been equivalence trial done by Dr. Manley et al. And this equivalence trial, they found that the treatment failure was almost similar in both the groups. But high flow babies, suppose they are failing on high flow and you need to intubate, before intubation, go through the path of CPAP. If you put them on CPAP, 15-20% of the babies will still don't require re-intubation. So practical guideline for high flow, you must maintain leak at the nose, give a humidified air oxygen mixture, keep temperature close to 37, position tubing down and away from the baby. So this is occlusive, this is bad, it should not happen. Look at that, baby is so healthy and so happy, and you should have a leak around the nasal prongs. Start at 5 to 8 liters per minute. In PQ, when you will be discussing, they are using more high flows because the baby weight is more. For bronchiolitis, the flow rate is more. Increase depending upon FiO2 need, work of breathing. It's a non-invasive treatment. Treat it like CPAP. Titrate FiO2 first, then the flow rate. If FiO2 need 50 to 60%, you first shift to CPAP, and then if the FiO2 need remains more than 50-60%, even on CPAP, you intubate. You should know when to bail weaning acidosis hypoxia. Wean FiO2 first. Once FiO2 is less than 30%, you decrease the flow in a decrements of 0.5 to 1 liter per minute. You can take out the baby of high flow if the baby is stable at a flow of 4 liters per minute. you must have a units protocol which is known to everyone. So to conclude my talk, primary mode CPAP is good, post-extubation CPAP or high flow. If the baby fails on high flow, shift to CPAP first before intubation. Nasal IPPV. So in nasal IPPV, the same interface is used, which is the CPAP one. The only thing is that we are also giving PIP, which is the peak inspiratory pressure, in addition to the PEEP. And there is certain set rate also. TI should be slightly high here. So what is the difference? If you look at the waveform, the nasal CPAP, you get only a single line. The single line is the line where only the PEEP is being delivered. And in nasal IMV, when you see the baseline of PEEP is there, but the PIP is also there. So that's the difference between the two. This is the nasal CPAP and that's the nasal IMV.
So, Dr. Naveen, please wrap up.
Yeah, sir. It's last 2 slides only. So what is the practical guidelines for nasal IPPV? The rate you can post-extubation 10 to 25, PEEP 4 to 6. The TI should be slightly longer, 0.4, 0.45, 0.3 to 5, and flow rate of 8 to 10. So synchronized has got some benefit, but nasal IPPV sometimes may help the baby, like it reduces incidence of extubation failure, reduces frequency of apnea. Additional safety efficacy data should be there. For the benefit of time, I am skipping this thing. So suggestions: nasal CPAP gold standard, high flow post-extubation state, babies having nasal trauma on CPAP, prolonged CPAP needs where kangaroo mother care, parental care is used, cautious use in babies less than 26-27 baby. If baby fails on high flow, start CPAP before intubating, and protocol for starting and weaning high flow should be there. NIPPV may be considered in the post-extubation state, but more machines and better synchronized methods are required. Thank you very much for the patient listening. Thank you, sir.
Thank you very much, Dr. Naveen, for that excellent presentation. You can stop your screen share. And I think since we are in that flow, we will just be moving right along with our next speaker for this evening, Dr. Kumar Ankur. He's going to be talking about the high frequency oscillatory ventilation, more so in newborns, because now in adults, they're not using it that much. But, this is one topic that is common to neonatal as well as some amount in pediatrics. So Dr. Kumar Ankur, he's a senior consultant neonatologist at BLK Hospital.
Thank you, sir. So am I audible?
Yes.
Thank you, Khilani sir, for inviting me for this lecture. And thank you.
Is your screen share on?
Yes, sir.
Okay.
Is it visible to you?
Yeah, it's visible. Yeah.
Okay. Because see, some of the participants who are in the general pool, one had mentioned, okay, sir, we cannot see the screen, but I can see it. So hopefully everybody is able to see it.
Okay, sir.
Yeah, it's visible. Yeah.
Okay. Thank you.
So at the outset, I want to congratulate IIP Delhi, the PCNI, for organizing this workshop in this COVID time. So without wasting much of time, I will be discussing about the high frequency ventilation, mainly in the neonates. So, so the objective would be that why and when we need high frequency ventilation in neonate, how to start, how to optimize high frequency ventilation, and how to monitor and weaning from high frequency ventilation, because it's a very big topic. So I would like to keep it more workshop type rather than giving much of theory. So I think in neonatology, we always heard 3 letter word. They are always traumatic for all of us, not for the parents, but as a neonatologist, we also don't want to see these 3 letter word, that is DPT, chronic lung disease, BAP, IVH, ROP, NEC, NDI. So any of the morbidity are interrelated. So if you develop, if your patient develop chronic lung disease, they ultimately would lead to some form of neurodevelopmental impairment. And probably what Dr. Naveen and Dr. Khilani sir had discussed about that, whatever mode of ventilation we are using, they would ultimately lead to injury to infant, those who are less than 1500 grams. And probably whatever complications we are discussing, they are mainly causing in the very low birth weight infant, not in the term event. So probably it was because of the intubation related and conventional ventilation related trauma, ultimately leading to ventilation induced lung injury, either because of barotrauma, volume trauma, atelective trauma, and biotrauma. And it was blamed to conventional mechanical ventilation. Indirectly, it is because of intubation related. So we want to avoid chronic lung disease. That's why nowadays we are following the ventilation, lung protective ventilation strategy, either in form of certain methodology in the conventional ventilations or using non-invasive ventilation, either CPAP, NIV, or if a patient doesn't tolerate conventional mechanical ventilation, we can give a trial of high frequency ventilation because they are considered to be a lung protective strategy. Over last 30 years, there are multiple trials have been done, almost 16 trials. What they have found that when high frequency ventilations were used either early or as a primary mode of ventilation in neonate, they were not more effective as compared to conventional mechanical ventilation. So incidence of chronic lung disease remained unchanged in both the mode of ventilations, either conventional or high frequency ventilations. Even two of the famous trials which was done in the adult patients group known as OSCAR trial and OSCILLATE trial, they have actually found either no difference or a higher mortality in high frequency ventilation cases. And recently concluded one of the famous trial known as a Vicky trial for congenital diaphragmatic hernia. Even they found that when they used high frequency ventilation in congenital diaphragmatic hernia, there was a higher incidence of mortality among infants, those who were getting high frequency ventilations. And author concluded that probably because of hyperinflation was causing more damage and ultimately mortality. So the crux of this is that we should use high frequency ventilation as a rescue mode, not as a primary mode. You should always give a fair trial of non-invasive ventilations first. So actually what went wrong with high frequency ventilations? Probably in last 1 decade, neonatal care has actually improved. There is a better ventilation strategy. What Dr. Khilnani sir has told you that we are using a low tidal volume for across all the ages. We are using 3 to 6 ml per kg of tidal volume. We are following strict SATS target. As Dr. Naveen told that we are following 91 to 95% of saturation, especially in a preterm baby. We don't know what the exact target should be followed, but we extrapolate that data for the term infant also. And we have actually very good ventilators, conventional ventilators now, where you can use all beds should be supported like in a PSV mode, pressure support ventilation. You can add volume guaranteed. And we are also following aggressive early weaning strategy, and probably few strategy like giving antenatal steroids to infant between 24 to 34 weeks, early CPAP, give a fair trial of extubation, early extubation, and give a non-invasive ventilation mode. Like Dr. Naveen told that CPAP and high flow cannula we can use is all infant. Early surfactant within 2 hours of life if CPAP fails, and giving surfactant through non-invasive technique known as a LISA, least invasive surfactant administration technique, targeting saturation very strictly, tolerating pervasive hypercarbia, and aggressive enteronutrition. But still, sometimes you would also require high frequency ventilation. So there is no clear-cut indication of what I told you that if your patient is not maintaining oxygen on a conventional mode of ventilation or progressive hypoxemias, then you should consider for high frequency ventilation. And if you have some problem with ventilations, like especially if the CO2 is in very, very high range, you're on a high settings of conventional ventilations, you should consider for high frequency ventilation. And you must know that lungs should be recruitable. I mean, if your patient is a case of primary PPHN where there is not lung-related issue, and if you give a trial high frequency ventilation, it would actually harm and probably increase the pulmonary arterial hypertension. So generally speaking, if the patient is on high PIP, that is more than 25, requirement of a FiO2 is more than 60%, if MAP requirement is more than 15, PEEP requirement is more than 8 centimeter of water, or oxygen index is more than 13 or 15, you should give a fair trial of high frequency ventilation. Look at this picture. So this, you can consider it as a one lung unit. So what we are talking about, we are talking about actually the alveolar ventilation, so that whatever the gas is going, it should go inside the alveoli and there should be an adequate gas exchange. So that means this area is the anatomical dead space, and this area is where the gas exchange is actually happening. And that dead space is actually 2 to 2.5 ml per kg for all neonates. And that is why we target tidal volume double the volume of the dead space, that is 4 to 6 ml per kg. That is why at this 4 to 6 ml per kg, the alveolar ventilation would happen and ultimately the gas exchange would happen. However, if you are using high frequency ventilation, you work around here. That means we target a very low tidal volume, that is only 2 to 2.5 and maximum up to 2.7 ml per kg with a higher rate. So as per convention, the higher rate, that means generally more than 80 beats per minute. So it's a low tidal volume and higher rate, and ultimately would improve the gas exchange, and probably because of the opening of the closed alveoli, diseased alveoli, what we call it is a recruitment of disease lung. So there are various mechanisms. They are all theoretical, and we should not waste our time discussing about the mechanism. There are generally 6 mechanisms. So you can read in the textbook that the bulk flow, there are dispersions, the pendulum effect, asymmetrical velocity profile, cryogenic mixing, and molecular diffusion. I'm not going into detail of mechanism of gas exchange. So in conventional ventilations, there are various parameters you monitor, you change to achieve your, or to increase your mean airway pressure, what Dr. Khilnani have told you, and ultimately achieve your tidal volume in the range of 4 to 6 ml per kg, whatever mode you are using, either a pressure mode or a volume dilator. However, in high frequency mode, there are only few variables. But before changing mode from conventional to high frequency, there are certain prerequisites you should follow. You should clinically examine the patient, check for the air entry. That means there should not be air leak. You should put a largest endotracheal size ET tube, and position of the ET tube should be at the right positions. There should not be any secretion in the tube. If there is secretion, suction, do suction, and preferably use closed suction. And the volume status should be adequate. You can use either a lung ultrasound or echo to rule out the IVC status and the fluid status of the lung. And then you can go for the recruitment maneuver. So I told you there are only 5 variables: the flow, FiO2, mean airway pressure, amplitude, frequency of it. So in some ventilators, there is flow parameters are not there, like in SLE 5000, there is only 4 variables like FiO2 map, amplitude, frequency. Like Dragon sensor, you would also find that there is a 1 parameter flow also. So here amplitude is also known as oscillations, or sometimes delta P. They would generally, they would create a wiggle and vibration indexes. So we'll discuss about what these variables are actually. So let's suppose your patient was on conventional mode of ventilation, like pressure supportive ventilation or volume guarantee ventilations, and now your requirement was very high and you want to switch over to high frequency ventilation. Look at this video. So you can see the patient is getting 13 of mean airway pressure on conventional ventilations, a FiO2 of 100%, PIP of 34, PWP of 7, and baby was on pressure support ventilation. So that means baby was on very high ventilation and still not maintaining saturation. Just switch on the high frequency ventilation. So there is only 4 parameters: frequency. Now mean. So mean, that is mean airway pressure. You want to increase 2 to 3 centimeters from the conventional ventilation. So now our patient was on 13 of MAP. So we have increased to 2 to 3 centimeters to 16 of MAP. So baby was already on 100% FiO2, we just continue 100% FiO2, and the delta P would be enough that should create vibration up to the level of the groin or mid thigh. Okay, so what we did here, and on the parameter, you are seeing that baby is getting 600% rate, and 1 parameter is showing that 300, and baby is getting mean of 17 on high frequency ventilation. So you add plus 2 to 3 centimeters from the conventional ventilation of MAP, FiO2 continue. Amplitude for starting, it should be in the range of 20 to 25. For a very small baby, 20 would be enough. For a larger term infants, the amplitude should be in the range of 20 or 30. That means you should see the vibration up to the level of the thigh. And to start with, we should not use frequency anything less than 10 to start the ventilations. For a larger infant, start between 12 to 15. For a smaller infant, for a larger infant, you start with a 10 of frequency, and for a smaller infant, you start with a higher frequency. So here the tidal volume is actually, you can see the tidal volume just 7.2. So we target tidal volume generally in the range of 2 to 2.5 ml per kg. And this dCO2 is just a mathematical calculation of what is the CO2 it's showing. So there are different type of this pressure curve. So, okay. So whenever you are ventilating a patient on high frequency ventilations, you will find two words. One is open lung strategy, and second word is closing pressure. What actually it is open lung strategy? It's a part of recruitment. So let's suppose we have started the patient on high frequency ventilation. You can see that all parts of the lungs are de-recruited. We have increased the map from 5 to 10 centimeter. Some part of the alveoli are opening, but still there are many parts of the alveoli, both in the upper half and the lower half of the lung, are still not opened up. So pressure was increased, that is mean airway pressure or MAP, mean was increased to 15 centimeter of water. Still, there are certain part of the lung are not opening up. Now the pressure is again increased to more than 5 to 20 centimeter of water. Now you can see the upper part of the lung is opening up, but still the lower part of the lung are not opened up. So there is a scope to gradually increase from 20 to 25 and 25 to 30 centimeter of pressure. And now at 30 centimeter of water, now you can see the almost all part of the lung are opened up and easily recruited over a few minutes. But how to monitor at the bedside? So at bedside, you would monitor the patient's saturations. So the saturation would improve gradually with the pressures, and after that pressure which open up all the lungs, then gradually you decrease the pressure over time. And you can see the chest X-ray will show you the chest X-ray to monitor whether the lung is inflated or adequately inflated or not. The second is the closing pressures. So in this video, I'm just showing you first thing that you look at the chest and the vibration. Here you can see, probably if it is visible, the vibration is present over the chest, abdomen, almost over the thigh. So we want vibration up to the level of thigh. So once all the lungs, all the alveoli, almost all the alveoli are getting recruited, and in this case, all the alveoli is recruited, and gradually then you can decrease the mean airway pressures 1 to 2 centimeter over 4 to 5 minutes. Now we can see that at the mean airway pressure of 12, the saturation is reaching 100%, and gradually what you can do, you decrease the FiO2 from 100 to gradually to up to 40 to 50%. Once you reach the FiO2 of 40 to 50%, then you gradually decrease the mean airway pressure. And the moment your patient saturation is decreasing or falling saturation, that would be the closing pressure. And after that, you have to increase the pressure to again recruit the lung and to know what is actually the closing pressure. So you can see the X-ray before recruitment. You cannot distinguish between the heart and the lung. It's a bad bad RDS. It is very difficult to differentiate. So once the recruitment is done, now the lung and heart is easily visible, and most of the part of the lung are already recruited. So bedside applications. So for oxygenation, you have to change the two parameters, two variables, FiO2 and mean airway pressure. Increase mean airway pressure 2 to 4 centimeter of water from the conventional mechanical ventilation to start with, until a clear improvement in oxygenation by step in a map by 1 to 2 centimeter over 2 to 5 minutes. We should avoid over-distension. After increase in oxygenation, decrease FiO2 and reach up to nearly 50% of the FiO2, and then try to decrease the map by 1 to 2 centimeter every 2 to 5 minutes until deterioration in the oxygenation. That would be known as the closing pressure. And then you reopen the lung until improvement in oxygenation. can decrease MAP until 2 to 3 centimeter of water over the closing pieces. We should target less than 10 coastal rate in the FRC, and we should closely monitor the hemodynamics. So how to monitor? We know that once the patient is on high frequency ventilation, it is very difficult to monitor the heart rate auscultation because there is a lot of sound, lot of vibrations. So what we can do, suppose you want to auscultate the heart, you want to auscultate or know the heart rate. What you can do, there is a mode, we call it standby. You can see the on high frequency ventilation, lung is vibrating and still open up. You just press the standby mode and wait for fraction of second, probably 1 or 2 seconds. So once the standby mode is done, so there is no amplitude, there is no delta P, but still baby is getting all the mean airway pressure, what we call is a MAP or positive end expiratory pressure. There is no de-recruitment of the lung, baby is getting all the P. So at this moment, you can monitor the heart rate, you can monitor, auscultate the chest, and you can auscultate bilateral chest and look for the air entry. So that is how we monitor without stopping the ventilator to know the exact heart rate status and the lung status. One of the question is that, can I give surfactant on high frequency ventilation? Yes, you can give. So there is always a question from my fellow that, sir, if you give surfactant on the high frequency ventilation, there is a lot of regurgitation of the, generally it does not happen. What we have to do, so you can see, first you have to remove the flow sensor from the patients, attach the ET tube, remove flow sensor from the ventilator because it will give an unnecessary alarm, just continue ventilations, decrease the delta P or amplitude to the near lower level. So we will decrease up to the level of the minimum. So in this case, the minimum level was 16 or 15. Still baby is getting same amount of mean. You can see the lung is still inflated. Now through this tube, because if you're using Fisher-Paykel circuit, there is a hole. You can use bronchoscope, you can use suction catheter, you can use orogastric tube. Through this tube, you can deliver all the desired dose of the surfactant without de-recruitment of the lung. Still, you can see there is no vibration. So patient is in standby mode and we are delivering all the surfactant. So you can avoid all sort of de-recruitment in this patient by using either standby mode or decreasing the amplitude or delta P to the minimum level. So after recruitment, before surfactant, lung was looking this. And after recruitment and plus giving surfactant, so almost all the lungs are opened up. Initially, the descending pressure, the recruitment pressure was, opening pressure was nearly 21 centimeter of water. After surfactant and recruitment, we have decreased the pressure to 9. This is the closing pressure. So can I do suction on high frequency ventilation? Again, yes, we can do, because if you are removing the patient from the ventilator, you can lose all the pressures. And again, de-recruitment can happen. And we know that this de-recruitment or atelectative trauma can damage the lung and release lots of protein and damage the surfactant also. So again, if you want to do suction, because what we found that generally baby on high frequency ventilator would require frequent suctioning as compared to conventional ventilation. So again, this baby is on high frequency ventilation, will decrease the delta P to minimum level. Yes, on the level 16. Still baby is getting that amount of mean airway pressure of around 17. There is no losing. There is only minimal vibration is going on. So lung is still inflated. Baby is getting mean airway pressure of 17. You can insert suction catheter through the same hole and you can do all suctioning. You can see without, at the time of doing suctioning, still there is no loss of positive end expiratory pressure. There is no loss of mean airway pressure and there is no de-recruitment at all. Or you can again do a check the standby and you can do suctioning also. So I think there is only two words at the time of intubation and ventilation. One is oxygenation and one is ventilation. So first we will discuss about ventilation. So Dr. Khilnani told you that CO2 is a gas where they can diffuse very easily. So we are intubating patient or we are shifting the patient from conventional to high frequency. In this case, because baby was retaining lot of CO2 in this blood gas. You can see the CO2 is 100 and pH is 6.83, and then we switch the patient to high frequency mode. So for one of the most common indication for high frequency ventilation is the high hypercarbia or persistent hypercarbia. So here there are two variables are working. Like in oxygenation, there was two variable working, MAP and FiO2, and here there are two variables, amplitude or delta P and the frequency. Let's see. So the baby was retaining lot of PCO2. So you can decrease the PCO2 by changing the tidal volume. And in the high frequency ventilation, you can change the tidal volume mainly with the change of frequency and to some extent by delta P. So if the CO2 is in the very high range, I would request to change the frequency not more than 1 or 2. So for higher PCO2, decrease the frequency from, we started with 10, decrease to 1 to 2, and 8. Because the moment you decrease 1 or 2 frequency, there is a lot of tidal volume changes, and this lot of tidal volume changes would lead to rapid clearance of the CO2 and ultimately will land up into the hypocarbia 18. So for a milder hypercarbia, you change amplitude, you increase the amplitude. But if the hypercarbia is in the very high range, you better change the frequency. So it is inversely proportional with the frequency and directly proportional with the amplitude, but never change both. That is the only message. The second is that hypoxemia. So here the baby is mild acidosis. PCO2 is in the normal range. So we are not going to change the frequency and amplitude, but the baby is just the PO2 is just 46 in case of PPHN. So in this case, we will change the FiO2 and MAP to improve the oxygenation. So this baby was getting FiO2 of 80%. So we have increased the FiO2 to 100%. But the best way to improve the oxygenation is to change the mean airway pressure first and then increase the FiO2. So we have increased the mean airway pressure from 18 to 21. So at one point of time, you increase the mean airway pressure 2 to 3 centimeter at a time, and then you change, wait for a few minutes, and then you can increase the mean airway pressure. So we started with this lung with the FRC of, you can see the posterior rib, 3-4 posterior rib, and the moment the baby was in high frequency ventilation, the lung was recruited, but still you can find some amount of hyperinflation is there. So normal diaphragm, we follow 6th rib anterior or 8th rib posterior, but anything more is considered to be hyperinflation. So this is one of the complication adverse effect of high frequency ventilation. We would find a rapidly changing compliance of the lung and ultimately leading to hyperinflation. So if you are finding hyperinflation, you will find flattening of diaphragm, increased lucency of lung, air and heart or herniation of lung to the other side. So ribs and diaphragm would be more horizontal. So better avoid this hyperinflation. So by frequently doing X-ray, you can avoid hyperinflation. What are the practical points at the time of high frequency ventilation? So suppose you have shifted from conventional to high frequency ventilation, you may find that, oh, baby is not improving high frequency ventilation. And we should again shift to, but wait, create map, know your opening pressure, recruit the lung, and then after recruitment, wait and go for closing pressure. Sometimes recruitment will be slow depending on the pathology of the lung, depending on the size of the lung, and depending on the type of high frequency ventilator you are using. Like Sensormatics is a very good high frequency ventilator. So you will find a rapid improvement as compared to Draga. SLE is also a very good inventor. Allows spontaneous breathing. So sometimes many of the residents ask that whether we should give a continuous sedation paralysis. No paralysis. There is a new pain and other trial. They have found that if you are giving lots of paralysis, they would ultimately increase the morbidity and mortality. Yes, intermittent sedation is acceptable, especially in case of PPHN. There is a theory that if you allow spontaneous breathing, you are giving some super CPAP that would actually help the infant. What is tidal volume in high frequency ventilation? You can see on this SLE ventilator, you will find this tidal volume, and tidal volume, that's 6.9. So I told you that the high frequency ventilation's target tidal volume is less than dead space. That is always less than 2.7 ml per kg. So to start with, you can decrease the frequency. This tidal volume would directly depend on the frequency. Lower the frequency, higher would be the tidal volume. So never use frequency less than 10 in very low birth weight infant unless and until your PCO2 is in very, very high range. Because if you are decreasing the frequency, ultimately the high power energy would be transmitted at the level of the alveoli, and then large volume displacement would be done, and they can lead to hypocarbia and sometimes lung damage also. So for very low birth weight infant, 1.6 to 2.5 ml per kg, start with 2.5 ml per kg and target with around 1.6 to 2 ml per kg and look the tidal volume always. And for term infant, you can anything between 2 to 2.7 ml per kg would suffice. How to wean from ventilator? I told you that once you reach your closing pressure, once your compliance would improve, disease would improve, once your FiO2 is near 30-40%, you can consider this patient to weaning from high frequency ventilations to either conventional mechanical ventilations or non-invasive. But how to choose and how to know? So if you look at the evidence, there is a very less evidence for weaning. So, but practically speaking, if your patient is on a low high frequency ventilation, low pressure, that means baby is getting only a CPAP. So probably if you directly extubate the patient from high frequency to non-invasive mode of ventilations, either CPAP or non-synchronous or synchronous non-invasive ventilation, the evidence is in favor of that. If you extubate the patient and directly put the baby on CPAP, you would get a less PPD rather than shifting from high frequency to conventional and conventional to non-invasive. Again, it is not evidence-based, but most of us are following this, and the evidence is also not robust in evidence, but evidence is in favor of this only. So to summarize, its high frequencies are lung protective as compared to conventional mechanical ventilation to some extent. We should know how to open the lung, how to recruit the lung, and keep them open by looking at their FiO2 and the saturation. There is only two indications: the persistent hypoxemia and ventilation failure, especially in cases of hypercarbia. These are the two major indications for high frequency ventilation. And you should know which lung is a recruitable lung. If the lung is very stiff, severe chronic lung disease, if the patient is a case of primary PPH and hypoxic respiratory failure, they won't work. It's highly effective for CO2 washout. The indication is that rescue is better than primary. Thank you.
Thank you very much, Dr. Ankur, for giving such a lucid talk about a very, very sort of current topic that many of the neonatologists are involved with. But moving right along, now we are noting down all the questions in the chat box and they will all be addressed. Our next speaker for this evening is Dr. Rajiv Uttam. He is the newly elected Vice Chancellor of the College of Pediatric Critical Care by the Indian Academy of Pediatrics Intensive Care Chapter. He is currently Director of Pediatric ICU at Max Hospital, Patparganj, Max Super Specialty Hospital. Dr. Rajiv Uttam has had an extensive training in UK. And then after that, he had moved to India in early 1996, 97. And then we had both got together to start the pediatric ICU at Apollo Hospital. That was the first sort of corporate pediatric ICU to go with many of the advances that we all had learned in the West, while Dr. Chugh, Dr. Singhi, everybody else was practicing in India. Then we all got together and formed a fellowship. So now we have 62 centers where we are training the Pediatric Intensive Care Fellowship, as well as the ventilation. So Dr. Uttam then after that moved on to Artemis Hospital also, but he's had an extensive training and experience in this area of ventilation. Now, disease-specific ventilation is one issue that comes up. Since we are already talking about the neonatal ventilation, he will probably not be touching too much on neonatal ventilation. But as we have in pediatrics, an age group coming from 1 month to 17-year-olds, you know, having different kinds of variety of illnesses. And it's a very, very difficult subject. Many of the questions that come up, and I'm sure he's going to make it simple enough for you all to at least get the basic principles of how to ventilate different diseases and different indications in pediatrics. I know 30 minutes is not enough to address this area, but what we'll try to do is the best justice, and at the end we'll take some of the questions, because ventilation workshop can take a whole week, 2 days. So in this particular 3.5 hours, what we are trying to do is to just sort of make you familiar with the basic principles, and then we can always address the questions at the end. So Dr. Rajivuttam.
Thanks for the lovely introduction, Praveen. Still remember the days we had Apollo, and continue to be great friends. Thank you very much, and the organizers, for inviting me here. We're just going to discuss briefly. In pediatric ICU, we see two common conditions. You must have all heard, is the ARDS, and the other thing is status asthmaticus. So we're going to first touch on ARDS and then move on to status asthmaticus once the time permits. So let's just take a case-based thing. A 5-year-old female presenting with complaints of cough and cold for 5 days, very common scenario you see in your ICU, fever for 4 days, and increased work of breathing for 1 day. On examination, her weight was 15 kg. She was febrile. Heart rate was 142. Respiratory was about 40. SpO2 92% on the maximum non-rebreathing mask. Blood pressure 88/54. Nino 64, okay for her age. She had intercostal and subcostal recession and bilateral crepitations. Liver was palpable, and her GCS was 15/15. So the question comes, you got to see, is this child require immediate care? Answer is yes. So what would you do next? We send all the labs. When you put the lines in, did a chest X-ray. Patient was started on BiPAP in an emergency, and then you got to see what the response of BiPAP is. After 2 hours of non-invasive ventilation, Dr. Chandrasekhar is going to touch on that in the next lecture. Her heart rate remained high at 146. Respiratory rate was 45. Saturation still 89% on 60% oxygen with a PEEP of 8. Blood pressure 84/50, more or less same. Still having severe subcostal intercostal recession, and she is somewhat drowsy. Her GCS now from 13 to 15. So obviously this non-invasive ventilation is not doing what it's supposed to do, and it's not good enough for her right now. So we're going to move on to give her more support. This is a chest X-ray which came back. You can see there is a bilateral haziness there. There is opacities. And now we're going to see what are we dealing with. Are we dealing with a bilateral pneumonia? Are we dealing with ARDS? Or is it a fluid overload? So you got to see very clearly the history. What the history shows. And the ARDS can look very, very homogeneous like you see over here on a chest X-ray. But if you do a CT scan, you will see it's a very non-homogeneous disease. So on chest X-ray give you an idea, but it will not give you a full picture that some areas of the lungs are proper ventilating, they are normal aeration, some are completely solidified, and some places in the lungs are there which are recruitable, and those are the portion of the lungs you will be working on. So we intubated that child with 5 cuff tube with the conventional ventilation with the following settings. You can use any mode. We commonly use PRVC. You can use volume control or pressure control if you're used to it. FiO2 is about 100%. PEEP, you start with 6. Inspiratory time 0.9. You can start with 0.7, 0.8 if you like. Rate appropriate for her age, which is about 20-25. Tidal volume 150 ml. Remember, she weighed, so it's about 6 to 7 ml per kg, and flow trigger at 1. So what changes should be done for her oxygenation to get better? Let's see with the ARDS started. If you're talking about a child with an ARDS, it started with the very first definition we had was the American European consensus criteria. It says that the ALI was you have a PF ratio of PaO2 in the ABG and your oxygen requirement, how much oxygen you're requiring, 60%, 50%. If it is less than 300, they call it ALI, and if it was less than 200, it was referred to as ARDS. There were bilateral infiltrates on the chest X-ray, and there is no left heart failure or the cardiac functions are normal. Then came the Berlin definition, which was mainly for adults, validated in pediatrics as well. we said that it has to happen within 1 week. Remember, in this child as well, she had cough and cold within a week. Chest X-ray again, bilateral opacities, which you cannot explain by effusions or a pulmonary edema. Origin of edema is respiratory, not cardiac, and they divide it into mild, moderate, and severe depending on your PF ratio of 200, 100, and less than 100. But the definition now we are using in pediatrics is from the pediatric ARDS group, the Pelisi group, and this is the which came in 2017. Just see here, it is also dividing the oxygenation in some children who are on non-invasive ventilation and children who are invasive ventilation. In a non-invasive ventilation, you can have a PF ratio of less than 300, and invasive mechanical ventilation, they had divided into oxygenation index of between 4 to 8, moderate between 8 to 16, and severe if your oxygenation index is more than 16. So this is the definition which we're using in pediatric patients now, and you must all be familiar with this. We did discuss the role of NIV in neonatal period. Is there any role of non-invasive ventilation in ARDS? So you have a patient, you have established that the patient is called ARDS, the history fits, the chest X-ray fits, the PF ratio or the SF ratio fits. What is the role of NIV? I mean, are you using, is high flow has got any role, or BiPAP has got any role? But if you have, it is definitely has a role, but you got to consider it early in the disease. So you cannot use it in a patient who on a high oxygen requirement is breathing at 50, 60, which should be breathing at 20, saturation is down in 80s, and then you just do a trial of NIV when she requires invasive ventilation. So you got to use it early. In mild ARDS, you have to use, if you're used to seeing using the BiPAP, there is a facial BiPAP, full face, and the nasal BiPAP. So full facial oronasal mask is better because you can have oxygenation and seal better. But if they do not show signs of recovery or improvement within a short while, please do not continue it, because there is increased risk of morbidity and mortality if you do not institute the invasive ventilation at the right time for these patients. So what are the key points in ARDS management? They are ventilatory and non-ventilatory. In a ventilatory, you got to, these are the basic principles, you got to keep it in mind, right? There is a hypoxemia. The pathophysiology of the ARDS is that there is a poor pulmonary compliance. There is a decrease and expiratory lung volume. That's why the Gattinoni coined this term, which is called baby lung. There is an increased dead space ventilation, and there is an increased intrapulmonary shunting. All this is going to cause a severe hypoxemia and a poor pulmonary compliance. So your ventilator strategies should be in line the pathophysiology to take care of these problems you have in ARDS lung. What sort of mode should we be using? This is a very common question. Shall I be using volume control, pressure control, PRVC, pressure control with volume guarantee? One mode is not superior to another. There is no outcome data to support any single mode. If you're comfortable with one particular mode, and when you're not there, you want to make some changes, your sister or your staff at your ICU should be familiar with that mode. So there is no point using a particular mode and no one else knows about it. So you need to use any mode you're familiar with. One is not superior to another mode. What are the basic strategy you use? Lung protective ventilation, you should be using low tidal volume, high PEEP or optimum PEEP, low inspiratory pressures, set PEEP to at 5 to 8 centimeters. There is no point putting your PEEP at 4 if you know it's an ARDS lung. So you need to start at least between 6 to 8 and then titrate. Tidal volume should be between 6 to 8 ml. In some children, which have got a very poor compliance and the chest compliance in their obese patients, you need to use more than 8 ml per kg initially. And you need to keep your plateau pressure less than 28 and definitely less than 35. And your oxygenation goal should not be that you need to have a saturation of only 100%, only SpO2. 88 to 92% is good enough. If you have your ABG, you can have your PaO2 between 60, 70. You don't need to a PaO2 of 100 and 120. So permissive hypoxemia and permissive hypercapnia, which we're going to talk about, should be acceptable to you at this stage to stop the or to decrease the incidence of ventilator-induced lung injury. PEEP has been discussed in the past lectures. It causes the lung recruitment, but it also has a deleterious effect. So you need to stand at the bedside with the ventilator for you to titrate the PEEP. So if somebody is on a PEEP of 8 and you want to see whether the PEEP is being effective or not, you got to go from 8 to 10, wait for a few minutes to see whether your saturation has gotten better, your heart rate has come down, and you have to look at your blood pressure. So PEEP can adversely affect your blood pressure, and sometimes you need to take hemodynamics, you need to take fluids, and you need to start them on vasoactive agents as well. So is the high PEEP better than low PEEP? There is no fixed formula. You need to go up gradually, and at a point when there is no improvement, you need to come back on it. There could be a worsening of PO2 and PCO2 if you're using too much PEEP or too little PEEP. So moderate PEEP is between 10 to 15. If you see the ARTS network where somebody is on 100% oxygen, the PEEP has gone up to 24 as well. But in our settings, most of the time in ARDS, we use PEEP about 12, 15. Hardly sometimes you need to go more than 15, but up to 15, most of the time they get better. So titrate PEEP according to hemodynamics and PEEP plat. It improves oxygenation and try to limit PEEP plat to 28 and maximum to 30. Is there any role of recruitment maneuvers? You must have heard recruitment maneuvers mean once you do the suctioning, you take off the ventilator for whatever reason, you're not giving enough PEEP, the lung alveoli collapse, and that collapse alveoli cause increase in PCO2 and decrease in PO2. To get that over, sometimes you need to give sustained pressure or intermittently increased pressure to open those alveoli, to recruit those alveoli to start playing a role in the ventilation. There are different maneuvers. One is sustained inflation, not too much favored these days because it causes a lot of pneumothorax. You go to a CPAP of 40, sometimes it causes pneumothorax. Now, stepwise incremental and decremental PEEP can be used, and this is the preferred method most of the time by most of the people. So you have done this, you have ventilated severe ARDS, you used all your parameters and all your pathophysiology, you have titrated your PEEP optimum, you have given him a high volume or pressure to keep your PEEP plat to 30, but patient is still hypoxemic. So that is called refractory hypoxemia. What do you do for that? There are few methods to deal with this. One is proning, the other one is high frequency ventilation, and then you have ECMO in very, very severe cases which are not responding. I don't know how many of you use proning. We use it very, very commonly in our patients, and since we have started using it for last few years, I think we've been using it for last 7, 8, 10 years now. We have noticed that our use of high frequency ventilator is almost zero. I've not used this personally for the last 2, 3 years. Most of the time, if you use it early when someone is not responding, they respond extremely well to prone positioning. And most of the studies has also shown that if you use it early and you use it for sustained period of time, it also decreases not only your morbidity, but your mortality as well. These are different studies. If you're interested, you can go through that, which has come in last few years. And this shows that your 90-day mortality was less in people who were proning. What is the role of high frequency ventilation? We all know it is very commonly used, and the high frequency is the one from neonatal specialist. It went to the adult world as well. But most of the time, most of the people in adult ICUs for ARDS, HFO, after few studies have shown that it is actually detrimental, has been taken out. But in pediatric patients, still, it is useful if you are not getting anywhere, say, with your conventional ventilation, you optimize, you have prone the patient, there is no use, and you can use high frequency ventilation if you have for Bigger patients, you got to use a sensormatics B, and of a smaller patient A. But there's definitely a role. You cannot discount it. There is no role, but the role is much less it used to be, and the role is before you put somebody on ECMO. So what is the strategies to correct to severe hypoxemia? Pressure and volume limited ventilation. You target your saturation and pH, reduce your FiO to 0.6, proning and recruitment. If there is no improvement, then you go to high frequency, and then you go on your ECMO. Permissive hypercapnia, as we talked earlier, please don't chase your PCO2. If your pH is okay, not less than 7.15, you can go on. PaO2 60 to 80, and then you have to have a PEEP of 10 to maintain your saturation between 88 to 92. So this is a stepwise thing. If you see your plateau pressure to begin with less than 30 or more than 30, you do your recruitment maneuver, PEEP titration, and then you go for your high frequency ventilation, no response. You can use nitric oxide, doesn't have much role these days, steroids, and then you have ECMO. Weaning again, depending on if your basic pathology has gotten better, the patient is hemodynamically stable. I think weaning is a whole lecture which we have, and we're going to talk about that. Spontaneous breathing, trial and extubation, and then we should avoid unnecessary prolonged intubation, and then take these children once you extubate them on some non-invasive support. So this was about ARDS. I'm sorry, this is too much of a thing to talk in about 20-25 minutes, but the basic idea was to tell you that how these patients look for what is the problem with oxygenation and how can we deal with this. Another very common thing is, luckily, we are seeing less of them because the primary care by pediatrician outside is much better. They are using steroids and nebulization much more frequently than they were using earlier. And the child coming with a status asthmaticus and being ventilated is very uncommon these days. Thankfully, with the better care in the community now. So this patient, 9-year-old, had a cough for 2 days, increased work of breathing and fever for last 1 day. Agitated, heart rate, respiratory rate was high. Saturation on 92%, on 12 liter, non-rebreathing mass, severe intercostal and subcostal recessions. Started on Duolin and 20 minutes 8 injection, max self given, and a minophyllin injection was started. Still remained agitated, heart rate was still high, high respiratory rate, still saturation was low. And there was still intercostal and subcostal recessions. So what would you next? You have optimized your therapy. The patient is not getting better, is still tachypneic, is still got a problem. What are you going to do for that patient? You can use non-invasive ventilation initially, continuous your beta agonist nebulization. The NIV had no effect. You started it, but the patient is not improving. So this is where the catch comes. If these patients are not getting better, you do not need to continue on your NIV and just on nebulization. This patient needs help. As Dr. Khilani had told you in the very first lecture, to ventilate somebody, do you need an APG? Answer is no. That clinically, if the child is getting tired and the child is getting now exhausted, whatever the saturation and your SpO2 says, you got to intubate that child and ventilate that child. So this is the pathophysiology you see over here. This is what happens in your airway obstruction. There is a progressive. In a normal lung, you inhale, exhale, test the baseline, and then that's what happens. In asthma, you don't have such a severe expiratory obstruction that they never touch the baseline, and there is a progressive hyperinflation. So you have a barrel chest, and there is an auto PEEP, which is already there, which is much, much higher than you have your normal PEEP, and that causes the problem. So you can see that there's a hyperinflation in the chest. Chest is barrel shaped, the heart is squeezed, and the lungs are hyperinflated. What is the mechanical ventilation? You can use the NIV, as I said earlier. Intubation should be done early. and cuffed ET2 with large diameter should be used, and you should be careful
yourself.
that you do not have a hypoventilation or hypertension there. Condition of alveoli in asthma, you can see this is what usually happens. You have airways which are normal alveoli, you have something which is totally obstructed, something which has got a ball valve effect. With each, it keeps on increasing, and the other one which is going to cause a pneumothorax in the problem. In asthma, you have a very slow rate of external filling and emptying. So you have to use a very prolonged IE ratio. You remember the problem is in expiration. There is an expiratory obstruction. So you got to give enough time for your lungs to empty out. It means you got to use a very low rate with prolonged expiratory time for your lungs to exhale proper air, and no air should be left at the end of expiration. So what is the role of NIV and HFNC? Multiple studies have shown benefit, but again, you got to use early, and the proper monitoring should be used. If no response, you have to go on invasive, and please do not try in hemodynamically unstable patient because they're going to get worse. So no mode is superior to another, but if you need to know your mechanics, whether what is your plateau pressure, what is your peak airway pressure going to be very high in asthma, you got to use a volume control mode. Otherwise, you can use pressure control, volume control, PRVC, whichever mode you want. So what is the role of PEEP? Use low PEEP because you already have such a high auto PEEP there. So you do not want to use any PEEP. PEEP of 0 to 2 is good enough. One very common mistake is that you do not ventilate somebody on your peak airway pressure, which is going to be very high because there is a high resistance to the airflow. So you do your airway ventilation on your plateau pressure, and you limit your plateau pressure to less than 28, like what we have discussed this in ARDS. Tidal volume should be low because you already have a lungs which are hyperinflated, and you should have a low PEEP. You should have a low rate and a high expiratory time. So low rate, shorter inspiratory time, longer expiratory time. Goal is to have sufficient time to comply with inhalation and expiration. This is what we talked about earlier, air trapping. This does not touch the baseline like this, and you have a lot of air already creating auto PEEP. Again, please have your permissive hypercapnia, permissive hypoxemia, continuous managing with bronchodilators and steroids. Please, somebody on a ventilator, you got to continue with the bronchodilators and steroids, don't stop it. And then wean the patient as tolerated. When you're weaning the patient and the patient is conscious, that time you have to use your PEEP for the auto PEEP to come over, and then you extubate that patient and take him on NIV or a high flow. Do we have time for this third case, or is a brief for your ICP management, Praveen? Are you there?
I think you can do it briefly.
Yeah, we can take about 5 minutes. Is that okay?
Sure.
Okay. So another very common condition which we see. So we have discussed ARDS, asthma, and all of you must be seeing who work in ICU. Common, that somebody has fallen off the floor, a child, and he's got a severe traumatic brain injury. He had one episode of conversion, bleeding from nose. He's got poor sensorium. What do you do with that child? You see the heart rate is 89, blood pressure is 130/80, his saturation is 100%, and his GCS is only 6. His right pupil is dilated, unequal, non-reacting to light, and he's posturing as well. So obviously this child is in trouble. He's got some sort of bleed because of he's got unequal pupil. His GCS is only 6. So anyone who's got a GCS that low, you got to intubate that patient regardless whether he's got SpO2 100% or he's got a blood pressure which is normal, because of airway protection and to decrease the ICP which this child is going to have with such a severe injury. So after applying cervical collar, you would use an RSI technique. Most of you must know who works in ICU, and then you hyperventilate or normoventilate him to maintain your PCO2 between 30 and 35. Don't try to decrease it less than 30. What is your goals of ventilation? Raised ICP, normal pH, normoxia, and normocarbia. So everything within the normal range. PCO2 between 35 and 40. Oxygen saturation above 94% to prevent the secondary hypoxemia. and to maintain your normal pH. So PEEP is adjusted to maintain oxygenation, and careful adjustment of PEEP is important, because if you use too much high PEEP, it is going to raise your ICP unnecessarily, and then you're going to have a decrease in cerebral perfusion pressures, which is going to make your head injury much worse. Overventilation is to be avoided. Optimization, use of neuromuscular blockers as per needs, especially initially you should be using. And you can also use ICP monitor, which is different types are available. We can discuss this some other time, but you can also have ICP monitor to know what is your ICP, and then with your mean airway pressure and your mean arterial pressure and ICP, you need to know what is your cerebral perfusion pressure. Is there any role of hyperventilation? Yes, if somebody has got a very, very high ICP, you want to reduce it briefly, you can hand ventilate them or hyperventilate them. But for most of the time, you got to make your PCO2 between 30 and 35. So during life-threatening raised ICP and impending brain herniation, you can use your hyperventilation. And in extreme cases, you can go for decompressive craniectomy and all that to get your ICP down. Thank you very much.
Thank you, Dr. Rajiv, for giving such a detailed talk in a short time. I know some people will feel rushed, but I think it's important that ARDS, low compliance kind of condition, which happens in pneumonia, as well as the high compliance kind of condition like asthma, those are all important ones that people should know. And then we also see a lot of patients with raised ICP, of course, PPHN in the newborn that has already been,
your video is not there.
Yeah. Can you see me now?
Yeah,
Yes. Yes. Thank you, Rajiv, for giving this excellent presentation. ARDS, asthma, ARDS and pneumonia, low compliance, high compliance disease, and the neuromuscular problems, ICP. So all those things where somebody has to see, one question that always comes up is, how do I ventilate the patient who has normal lungs? So if you can just briefly address that, and then we'll move on to next talk. And then at the end, we'll take up all questions. We are collecting all the questions.
I mean, the question is that suppose you're ventilating someone who does not have a pneumonia, who does not have ARDS or asthma, he's got a normal lungs.
Right.
And you are ventilating him for, say, for a traumatic brain injury, or you're ventilating him for Guillain-Barré syndrome.
That's right.
You've got a muscle weakness. So the principle still remains that you got to ventilate them with as low volume as possible. Don't go on 8 to 10 ml per kg, still 6 to 8 ml per kg to maintain their normal tidal volume. And when you start initially, just to make sure that the chest is rising, not over rising as well. And your peak plateau pressure should be maintained low. If you have a normal lung, your plateau pressure should be low anyway. But if you have normal lungs and you ventilate them with a higher tidal volume, they're going to get worse. So
and FiO2?
We have ventilated patients who do not have normal lungs even on 21%. So somebody on a ventilation does not mean that you got to use 30, 40%. You can just use 21%. If somebody has got a Guillain-Barré syndrome and you do not need to do anything other than the airway protection for him, and you got to just give them minimum ventilator for them to until their muscular power comes back, I think 21% is good enough.
Yeah. Thank you, Rajiv. I think we will move on to our next speaker for this evening, Dr. Chandrasekhar Singha. He's my colleague right now, currently at Rainbow Children's Hospital. He has trained IDPCCM, as well as he has trained at Toronto Sick Kids Hospital, has done a full pediatric intensive care fellowship. And his topic is also something that is becoming more and more popular now. And I'll tell you, in the past 10 years, what we have seen is many of the patients that we were ventilating when we put them on NIV, or even when we have put them on HFNC, high flow nasal cannula, the rate of ventilation has gone down. So I think to bring out this important aspect, and as to how every unit can learn to do HFNC and NIV, I think it's a very, very important topic. So Dr. Chandrasekhar is going to talk about NIV and HFNC in pediatrics. Dr. Chandrasekhar, kindly unmute yourself.
Yes, yes sir.
And screen share.
Just hold on.
Screen share. Right.
Yeah. Can you see my slides?
Yes. So please go to slideshow.
Okay. Thank you, sir, for good introduction. And I also want to give thank you to organization to give me the opportunity to participate this ventilation workshop. So my topic is basically non-invasive ventilation and high flow nasal cannula. So, define as a non-invasive ventilation, basically it refers to application of ventilatory support using techniques that do not require endotracheal intubation. Basically, by any means or by any devices, you give a positive pressure without intubating the endotracheal tube. So nowadays it's become very common. People are moving from the invasive to the non-invasive because there is a many benefits of non-invasive ventilation we are going to discuss in the next few slides. So what are the advantages of non-invasive ventilation? So number one, NIV leave the upper airway intact, so you are not intubating the endotracheal tube, and it decrease the risk of airway trauma and preserving the natural defense mechanism in the upper airways. So it's very important part. So you are preserving this normal humidification of the upper airways. The next most important advantage is the patients do not require paralytic agents, though we are less frequently used for paralysis except the severe ARDS for the short period of time. But obviously the patient who are intubated, they definitely need some kind of sedation. So though in NIV we use sedation, but the amount of sedation is very less.
And slide show कर दीजिए, slide show नहीं हुआ.
Okay.
Yeah, okay now? I think that's a bigger, yes. Yeah. Yes, thank you.
Now, obviously, as we are working in the private sectors, our main concern is one of the expenses. We always try to keep the patient as at a low duration in the ICU, so that their overall hospital stays less. And whenever we started using this NIV thing like non-invasive ventilation, either in form of BiPAP, CPAP, or high flow nasal cannula, and the number of invasive ventilation tremendously decrease, and the number of hospital stay also tremendously decrease. Suppose when patient need a intubation, like some kind of respiratory distress, obviously you need sedation therapy, some other associated adjunct therapy. So even after a patient extubated from the invasive ventilation, because of all this weaning from the medication like sedation, patient needs take little while to get out of the pediatric ICU. Now, what are the indications and contraindications? So the most common indication of non-invasive ventilation is any kind of respiratory problem. So any kind of respiratory distress, like in form of if patient have a significant tachypnea, so we can start any form of NIV as early as possible, so that patient cannot move to severe kind of respiratory distress, needs endotracheal intubations. Or if you can able to do a blood gas, if blood gas shows some kind of mild to moderate acidosis, so this is another indications. And as I said, any kind of respiratory distress, if patient is deep snake, patient is using accessory muscles, or if patient have a paradoxical breathing, always we can give a NIV trial before we move for invasive ventilation. Now, what are the contraindications? The absolute contraindication, obviously, if patient in the respiratory arrest or cardiac arrest. So in this patient, obviously, you don't try NIV, you directly go for invasive ventilation. Or if patient is hemodynamically unstable, like if patient have a hypertension or patient have some kind of arrhythmia, so this kind of patient needs invasive ventilation. So this kind of patient never try for non-invasive ventilation. Or if patient have a other kind of organ failure apart from the respiratory failure, if patient have a renal failure, need dialysis, or a small baby need peritoneal dialysis, in that case also better prefer to have an invasive ventilation. Or if patient is inability to protect the airways, so if a patient is unconscious, patient is drowsy, so in that case is NIV is not indicated. So in that case, you have to go for invasive ventilation. And obviously, if patient is not able to tolerate the NIV, patient is uncooperative, even after giving mild kind of sedation. So in that case, you need say invasive ventilation. And the relative contraindication is if patient have a significant secretions. Again, it's very difficult to manage significant secretion with NIV, with facial mask or the nasal mask. So in that case, we preferred invasive ventilation. Or if patient have a nasopharyngeal abnormality or oropharyngeal abnormality where there is a significant leak after applying a nasal mask or facial mask. So how they help this NIV things? So first of all, it decreases the work of breathing by giving a positive pressures, and it increases the functional residual capacity, FRC. So by increasing the FRC, it's try to open up the collapsed alveoli, and thereby it improves the gas exchange and is reverse the hypoventilation. And again, another most important things, by giving a positive pressure, it's maintain the patency of the upper areas. So in that case, some kinds, sometimes if patient have a like obstructive sleep apnea, by this mechanism, by maintaining the upper area patency, the NIV has a significant role. So how can we apply NIV, non-invasive ventilation? So we can, these are different from, so now we commonly uses this, what is called SSFNC, humidified high flow nasal cannula. So I'll discuss briefly the later part of the presentations. The another common mode of presentation of this, the NIV is the CPAP. We are all of us familiar with the CPAP. And now another standalone therapy of NIV is the BiPAP. So you can apply BiPAP either from the main ventilator, what we use for the invasive ventilation, or you can apply from these standalone BiPAP machines. And now another thing is the intermittent positive pressure breathing, and another is the bi-level nasal CPAP. So this is the another important thing to how to select the interface. Like you want to use a full mask, like the mask which will cover your mouth as well as the nose, or you can use a nasal mask, or you can use a nasal prong. So in case of children, it all depends, like trial and error. Like some baby, they don't tolerate the full mask. So in that case, you can try a nasal prong. And some baby, they don't even tolerate the nasal prong because it causes a little bit of irritation. Then you can try a nasal mask. with appropriate size. Again, this is very important because if you don't apply a appropriate size of interface, it will give a significant leak and your purpose will not fulfill. Like the pressure, the adequate pressure won't be delivered through the airways. So the selection of the interface is very important. So these are the different kind of interface. I'm showing, this is the so this is the like a small mask. Even sometimes the nasal mask in the adult, you can apply a small baby as a full face mask. So this is a nasal pillow. Again, the nasal pillow for adults, sometimes we can use in the small baby like a some kind of the face mask or full mask to give a positive pressure ventilation. So what is bilevel positive pressure, bilevel positive airway pressure? So here the bilevel means you give pressure both in the inspiratory phase as well as the expiratory phase. So when you give a pressure in inspiratory phase, it's called IPEP, high level pressure during inspiration. And when you give pressure in the expiratory phase, it's called EPEP, means you give it during the EPEP phase, you give a little bit lower pressure. It's like usually when you start BiPEP, you start with EPEP of maybe 4 to 5 or IPEP of maybe around 10 or 12. So from start with lower pressure, then from lower pressure you gradually increase the pressure depending on the patient response. But when you give a high pressure initially, sometimes the machine will give a high pressure at the initial part, the patient may get some kind of discomfort. So it is always advisable to start with the low pressure and build up gradually depending on the patient tolerance. And again, you can set up your rate as per the patient's age, or patient can take their own breath depending on this become a time trigger. And in that case, if patient have a spontaneous breath, you can give some backup rate. If patient is not breathing in its own, the machine will give a backup rate we have set. So continuous positive airway pressure, CPAP. So CPAP delivers a constant level of pressure support to the airway during inspiration and expiration. So it's usually give pressure from the as low as 5 centimeter, 4 to 5 centimeter. We can give up to maximum 10 to 12. So usually if suppose patient is not tolerating of this mass of high pressure CPAP, so obviously they need of some kind of other kind of therapy. Either you can try bilevel like BiPAP, or maybe patient needs a invasive ventilation. And this patient, the CPAP is spontaneous, like there is no respiratory cycle limits. Patient will trigger his own respirations, and they delivered through the several external interface. So we can use different interface like oronasal mask, nasal mask, nasopharyngeal prong, or nasopharyngeal prong, or single nasal prong. So these are the different interface we can try. So another new thing is nasal intermittent positive pressure ventilation. So here, this is a new form of NIV, provides periodic increase in positive pressure above baseline fixed pressure. So you have basically here you have a 2 flow meter. So one flow meter will give a constant pressure like a CPAP, and another flow meter intermittently you give another pressure from the different flow rate. So it's like some kind of sigh breathing. So by doing this mechanism, by these 2 flow meter use, they give the 2 level of CPAP. Okay, so when you put a patient on the BiPAP, NIV, so how do you know patient is responding to your therapy? Because if patient is not responding to your therapy, patient needs maybe invasive ventilation. So it's most important, after applying a BiPAP, you should stand on the bedside and see the patient response by monitoring the few parameters. So one is the after giving adequate pressure, respiratory rate should be decreased, and there should be decreased work of breathing in the form of retraction, accessory muscle use, and there is reduced airway occlusion pressure. Suppose if you are applying a BiPAP or NIV for the upper airway things, your this occlusion pressure have to be improved after giving adequate pressure. And the most important, you have to see the improvement of the oxygenation by doing a continuous pulse oximetry or by intermittent blood gas. And obviously, if you're applying for the collapse like atelectasis, there should be significant improvement after applying a pressure with NIV by doing a chest X-ray or by auscultation on physical examination. So, okay, patient, you put a patient on the NIV. So when you when you shift the patient from NIV to the invasive ventilation. So these are some of the parameters you have to monitor. If patient have a progressive respiratory distress in spite of giving an adequate pressure of NIV, or if patient have a persistent tachypnea in spite of adequate pressure, or patient have persistent hypoxia despite supplemental oxygen. So in the NIV, there is a provision to give extra oxygen also. Suppose after giving oxygen and adequate pressure, if the patient oxygenation is not corrected, if SpO2s remain low, less than 94, less than 90%, so you have to move to the invasive ventilation. Or if patient develop hemodynamic instability, suppose as I mentioned, so one of the absolute contraindication is if patient have hemodynamic instability in the form of hypertension or dysarrhythmia. So suppose at the beginning, when you start the NIV, patient have a normal blood pressure, but after sometimes you notice the patient blood pressure is dropping, patient having hypotension, patient having tachycardia, it means your NIV is a failure. So you can't continue the NIV. So in that case, if you continue the NIV, patient may develop cardiorespiratory arrest. So this is always preferable if patient develop hemodynamic instability, patient having tachycardia, patient have a profuse sweating, you should switch to the invasive ventilation. Or obviously, if patient have a repeated vomiting, obviously in that case, you cannot continue the NIV. And excessive secretion also another is a relative contraindication or the NIV failure. Or if the patient is anxious, patient is agitated, patient is it means patient is so this is another sign of hypoxia. If some patient is agitated, hypoxic, very anxious on the NIV, it means patient is hypoxic. So in that case, patient is an invasive ventilation. Or increasing lethargy or worsening of the mental state. So this is again indicate indirectly patient's CO2 is rising, patient is developing most likely respiratory acidosis. So this patient obviously needs invasive ventilations. So I'll talk a little bit about the high flow nasal cannula, which is nowadays become a commonly used in all of the pediatric ICU, in the NICUs, even in the adult ICUs, because of the age of you can use this NIV very easily, this high flow nasal cannula very easily, and the patient tolerance is very high. So what the high flow nasal cannula means, so you apply constant FiO2 by delivering the gas at the flow rates that exceed the patient inspiratory flow rate by using the device that enter in a fixed proportion of the room air. So basically by high flow nasal cannula, you provide warm humidified oxygen in high flow. So the oxygen and the air you are providing is the warm and humidified. So what are the indications? So any kind of respiratory distress like bronchiolitis, pneumonia, mild to moderate pneumonia, congestive cardiac failure, hypoxia, saturation level is less than 94%. You can start with high flow nasal cannula, or even some of the ICU, some of the units nowadays people are extubating or people are weaning from the BiPAP to the invasive ventilation of the high flow nasal cannula. Or in case of apnea of prematurity, so there is a definite role of high flow nasal cannula. So it's extend the upper ARS, thereby maintain the patency and decrease the obstructive type of apnea and prematurity. So what are the contraindications of this high flow nasal cannula? Suppose most of the time high flow nasal cannula provide through the nasal passages. So if patient have a obstruction or coronary atresia, you cannot apply a high flow nasal cannula. If patient have a respiratory failure with altered sensorium, so obviously this patient needs some kind of invasive ventilations. And inability to protect the airway with decreased level of consciousness. The same thing, suppose the patient is unconscious, patient is drowsy, there is a doubt of protection of the airways, aspiration of the secretion. So in that case, you cannot try high flow nasal cannula. And obviously, if there is a trauma or surgery in the nasopharyngeal area, on the facial area, you cannot apply a SFNC. So how does it work, a high flow nasal cannula? So basically, it provides continuous flow of gas through the nasopharynx and washes out the oxygen depleted air so that upper airways effect become a reservoir oxygen rich gas. So basically, by decreasing the filling the dead space with the oxygen rich gas, it's thereby replace the normal nitrogen in dead space with the oxygen. And so it's reduced the overall dead space, resulting in alveolar ventilation greater than fraction of the minute ventilations. So obviously, again, it's deliver the warm and humidified gas. So when you deliver a warm and humidified gas, it's preserve the airway functions. So it functions the airway mucosa, mucosal airway function is intact. So thereby, patients can effectively remove the normal respiratory secretions. So thereby, it prevents the airway drying and subsequent lung atelectasis and collapse, and maintain the patent airway and prevent the atelectasis by giving a constant distending pressure in the upper airways. And second important thing, you can deliver oxygen accurately with the blending mixer through the machine. You can generate a constant number of FiO2. So the oxygen toxicity by giving by other devices like non-breathing mask or nasal prong, we can decrease the amount of oxygen toxicity by giving a unmeasured oxygen by other devices. And again, it's reduced there is a reduction of the inspiratory and the work of breathing by distending the nasopharynx and mechanically extending the airway. As I mentioned, so it extend the upper airways, so thereby decrease the work of breathing. So these are some of the components of the high flow nasal cannula. So obviously you need a nasal cannula, appropriate size nasal cannula. So depending on the manufacturer like Optiflow or like the Fisher-Paykel have the devices, so they have a certain guidelines, like depending on the age and weight of the baby, you can choose the nasal cannula with different color code also. So, and there is an inspiratory limb, and there is a blender here. So you can blend the air and the oxygen so that you can give your required FiO2, so that you can decrease the oxygen toxicity by monitoring the other parameters. So these are the same devices. And this is another device here. So here you can see there is no this blender, oxygen the air blender. So this is work like a turbine. So from here, actually from this machine, you can control the flow and the FiO2. The same machine in the enlarged form. So here through this turbine, you can regulate the flow as well as the FiO2. But here you need a flow meter and the oxygen blender. So these are some of the cannula size from the chart. You can choose the cannula size. Suppose in case of premature baby, if the baby's weight is less than 10 kilo, and you can item code this 12 size nasal cannula you can use with a maximum flow of 8 liter per minute. So in case of pediatric size, you have you can apply up to 12 to 22 kilo babies, and here maximum flow is 25 liter per minute. So depending on the size, in the age of the baby, you can choose the cannula size. And the number two, again this which machines you are using, like you are using a like oxygen air blender, your cannula size will be different. And if you are using that other Fisher-Paykel types like AirVO2, your again this cannula will be different depending on the flow. So how to initiate? So obviously the first priority are the indications. Proper indications have to be there to start the high flow nasal cannula. And first of all, you choose the appropriate nasal cannula. And when you apply a appropriate nasal cannula, another most important thing, the cannula size or cannula should not cover the whole nose. So there should be at least 50% space so that it cannot obstruct the nose completely to generate adequate flow. And when you start a flow, you start with the low flow, like you start with 0.5 ml per kilo, and you can go up to maximum 2 liter per kilo. And at the same time, by giving the oxygen, you can regulate FiO2 as well. So obviously, another most important parameter, as I mentioned, the monitoring. Both in case of high flow as well as the NIV monitoring is very important, because when you put a patient on the NIV, your this machine like ventilator should be ready on the bedside. And if the patient shows any sign of failure of the NIV or the high SFNC, you should put the patient on the invasive ventilation. So the monitoring parameter on the respiratory rate, heart rate, and degree of chest injuring. So after putting on the high flow nasal cannula, these parameters should be improved at least 20% from the baseline. And all infants should have a nasogastric tube so that you can decompress the stomach to have optimum results. And the nostril should be always patent, and you have to make sure this nostril is patent by frequent suctioning. And you do as I said, you do a oral and nasal suctioning very frequently to keep it patent. So though the complication is rate of SFNC is very low, but there is some rare complication like pressure sore around the nose. If you give a high flow, patient may develop a brain trauma and pneumothorax. It may cause nasal obstruction, or sometimes if you don't monitor adequately, patient may develop life-threatening hypoxia. So to summarize, so NIV has gained popularity even in younger children for last 2 decades. The most of the units nowadays, they are using more of NIV in the form of high flow nasal cannula, BiPAP, CPAP. The NIV keeps the upper airway intact, decreasing the risk of airway trauma, and preserve the natural defense mechanism in the upper airway. So it can be used in the chronic disease like obstructive sleep apnea, cerebral palsy, neuromuscular disease like mitochondrial myopathy effectively, and obviously decrease the hospital stay overall, and facility for invasive ventilation must keep available when you do a NIV or high flow nasal cannula. Thank you.
Thank you, Dr. Chandrasekhar, for that exhaustive. Actually, it's a major topic because HFNC, all aspects of NIV, but you did justice to it. It's good. I'm sure we are accumulating lots of questions. Some of them we are sort of ongoing answering because some people may not be able to stay till late, but it was an excellent presentation. And I think we'll move on to our next speaker. Thank you, Dr. Chandrasekhar. Our next speaker for this evening is Dr. Rachna Sharma. She is Director of the Pediatric ICU at the BLK Super Specialty Hospital. She is trained in IDPCCM at Gangaram and has had extensive experience, and we have worked together at BLK also. And her topic, and it's a very difficult thing to interpret, but I think she has made it simple by giving repeated lectures on this, is graphics. Graphics, the graphics that get displayed on the ventilator, how to interpret that, how to interpret problems early by looking at the graphics and being able to, detect things like hyperinflation or airway obstruction or artifacts. So I would not take any more time in the introduction. Let Dr. Rachna, I hope your screen share, right?
Yes, sir.
Yes, Dr. Rachna, all yours.
Thank you, sir, for the kind introduction. So today I will be talking about pulmonary graphics, which is a very integral part of the ventilator, or I would say ventilating a patient. Now, without taking much time, I'll start with my topic. What I believe and feel that without, like I have worked in an era where there was no graphics on the ventilator and we used to just set the knobs. And
so Rachna, the screen that I'm seeing right now is only, is sort of, that presentation is not there, is it?
Okay.
Can you all see the entire presentation, the PowerPoint? Screen is showing multiple sort of icons.
Okay. So now,
Rajiv, let me just make sure. Rajiv, please unmute. Please unmute, Rajiv. Unmute, just so we
sorry,
know.
what I'm saying is we can just see some icons.
Yeah,
that's right.
Only this icon, yeah.
So please,
what I will do is I'll share it again.
No, Rachna, just press on that with the presentation of yours.
Yeah.
Yes, sir, I'll share it again.
Yeah.
Sir, now can you see the screen?
Yes.
Yeah. Yes.
Yes, we can see that. Now you go to the slideshow, please.
Yeah.
Go to slideshow. Yes, we can see everything now, starting with introduction.
Okay. So
Okay.
right now, what I was saying is that I have worked in an era where I would set some parameters on a ventilator, and there would be no graphics for me to see how the patient is responding to those parameters which I have set. To the era when I saw that the graphics would come and we would be able to interpret. So basically, it was a learning process which I have over the year, over 15, 16 years, have learned that just by looking at the graphics, how comfortable can I be in intubating a patient. Now, the graphics would include scalars and loops. So I'm coming to basically, I'm going to talk about a very important thing, that is how the waveform would look like on a ventilator. So whenever we have a pressure time scalar, that is whenever you have a pressure on the x-axis and the time on the y-axis, time on the x-axis and the pressure on the y-axis. So in those cases, whatever you may see is something like, square waveform, some ramps over here. You may see ascending ramps, sinusoidal patterns. Then you may see like, same square, sinusoidal, ascending, descending, or exponential decay. So basically, to remember, merely square waveform and some ramps and some decay, that is what you see as a waveform. Now, how these waveforms are produced? This is basically depend upon the interaction between the pressure and volume, which is basically determined by the compliance. And second is the flow and volume, which is basically determined by the resistance. These are your control variables. Now, before I go on to explain the waveforms, we should know that the waveform is maintained or formed by the three variables. One is the trigger, that is whether the patient is triggering or whether the ventilator has triggered the breath. And then it is the limit which we set, whether the pressure is going to be a limit, volume is a limit, or time is a limit. And third is the cycling. Cycling is nothing but just when the inspiration stops and the expiration begins, and that is your cycling. Okay. Now, so I'm going to talk about scalars first. In the scalars, I would be talking about flow time scalars, pressure time scalars, and the, what is this? Oh, don't do it this year. So I will be talking about scalars. So this is a pressure time scalar, this is a flow time scalar, and this is a volume time scalar. Now this is the most important slide which one should understand. If you will see that when I'm looking at a volume control ventilation, then the most important scalar which we have to look is a pressure time scalar. Pressure on the y-axis and time on the x-axis. Here, look at this waveform and look at this waveform. This is what is the difference between volume control ventilation and the pressure control ventilation. In the same way, if you will look at the flow time scalar, you will see here there is a square and here it is a ramp. So, and volume time scalar, there's not much difference between a volume time scalar between the two modes of ventilation. So I'll take all these scalars one by one, and I will also discuss what is the importance of each scalar. Talking about first the pressure time scalar. So in the pressure waveform, as I just told you, when you have a volume mode, that is you have volume control ventilation, then the shape of the pressure waveform will be a ramp for mandatory breaths. So if it is not a mandatory breath, you may have a trigger over here. Otherwise, you will not have any negative deflection, but a breath similar to this in a ventilator triggered breath. Or if it is a patient triggered breath, then you will have some negative deflection. As a vis-a-vis, if you are ventilating a patient on a pressure controlled mode, then you would see a square shape. It is very easy to, you don't have to remember, you just have to remember one thing. What the important thing is that in a pressure controlled ventilation, you have set pressure as a limit. So what happens? The pressure is increased to the level which you have set, and then it remains same throughout the inspiration. That is how it is. And then the cycling happens and the expiration happens. So you will get a square pattern in a pressure controlled ventilation. Okay. Now I'm going to show you a pressure ventilation. So if you will just look at this video, you would appreciate that this is a pressure control ventilation where you are seeing these square waveforms in a pressure time scaler. So the important thing is that the moment you will see your ventilator, by looking at the square waveform in the pressure time scaler, you would appreciate that this patient is on pressure control ventilation. Now, what happens in a pressure control ventilation, that you have a very physiological flows or decelerating flows on a flow time scaler. Okay. Now, I'm coming to a volume oriented ventilation. As I told you before, that in a volume oriented ventilation, we see a ramp pattern. Now, trigger will be seen only when the patient is triggering the breath. Otherwise, what will happen, that after a PEEP, whatever you have set, this is the PEEP which you have set, you will see that the pressure is rising to achieve a set volume, and then there is a expiration which is happening. Now, this volume control mode or this ramp pattern is a very important mode, because by doing few maneuvers on this volume controlled ventilation, we can determine the physiology of the patient. See how it is. Now tell me the difference. I'll just show you this video. Here you are seeing a same ramp kind of a flow. You are seeing a ramps, correct? Now tell me what is happening. What's the difference? These both are volume control ventilation. This is again a volume control ventilation. So can you see some difference over here? Can you see the change in the pattern here and the difference over here? I'm sure you can appreciate the changes. Why these changes are there? So the very important thing which I have done in this video is that I have put a inspiratory hold. Now this inspiratory hold is responsible for some plateau. So what is this inspiratory hold is going to give me? So I'm going to discuss about this in next slide. So look over here. This is a volume controlled ventilation where I have put a inspiratory hold. During this inspiratory hold, there are no flows. So whatever pressure which are required to overcome the resistance of the bronchus has gone away. So this pressure, the PIP over here, was including both resistance and compliance. The moment we have stopped the flows, that is we have put the inspiratory hold, the pressure now which we are measuring here are the plateau pressures. What pressure? Plateau pressure. Now what are these plateau pressures? Plateau pressures, as you can determine now, that when there are no flows, then these plateau pressures are basically telling you about the compliance or the elastance of the lung. So remember one thing, PIP, that is peak inspiratory pressure, tells you about both resistance and compliance, vis-a-vis plateau pressure basically is telling you about the compliance of the lung. The moment we see this and the difference between the two tells you a lot of things. What? Let's see. Okay. Now this is your PIP, this is your plateau pressure, and this is a trans-airway pressure. So trans-airway pressure is the pressure which is required to overcome the resistance of the air bronchogram, through which the air is flowing right from your nostril to the alveoli. Okay. Now what is happening over here? This is your PIP, this is your P-plat, this is a normal pressure time graph. Now, if you have a high resistance, what will happen? Your PIP would be here. However, the moment the flows will stop, the P-plat will give you a compliance of the lung. At that time, the difference between PIP and P-plat will increase. So trans-airway pressure is increased. So just by looking at this graph, one can deduce that we may be probably dealing with a restrictive airway disease. Now, vis-a-vis, if you will look at the lungs which have low compliance, what is happening here? Both PIP and plateau has gone up. What has happened? PIP has also gone up and the P-plat has also gone up. So the difference between both has remained constant. The difference between PIP and plat has remained constant. The trans-airway pressure are same. That means the compliance of the lungs are bad. That means we are probably dealing with a restrictive kind of a disease. Here, where the trans-airway pressures were increased, we were probably dealing with the obstructive airway kind of a disease, or it could be the secretions, it could be a blocked tube, whatever. But this basically tells you that there is increased resistance in the flow of air. Vis-a-vis, if you will look at this pattern where the PIP and P-plat both have gone up, but the difference has remained same, we are saying that the compliance of the lung has gone out, and the reasons can be numerous. Okay. So moving forward. So we can basically take any questions regarding this later on. So moving forward, I'm going to discuss now the flow time scaler. Now, when I'm talking about flow time scaler is a very important scaler which gives you a lot of information. Now, if I will look at these two flow time scalars, if you would appreciate, we have already discussed the pressure time graph. By looking at the pressure time graph, one can say that this is basically a pressure control ventilation, because we are having a square waveform on the pressure time graph. In a pressure time graph, if you find this square waveform, the flows in a flow time scaler, the flows during the inspiration would be a descending ramp. So what do you mean by descending ramp? That the flows will go up and then they will decay exponentially. This is what is the most physiological, and that is how we breathe. And these are also called as decelerating flows. There are a lot of literature which has suggested that decelerating flows are better, more physiological, and I will be talking about the advantages of the decelerating flow. Now, if you will look at the volume-oriented ventilation, here you can look at the graph. Now, just by looking at the graph, which is a ramp in the pressure time scaler, we can say that this is a volume control ventilation. And now look at the flows. So what is flow? Volume upon time. So what is happening? We have fixed the volume. So the flows will rise to a particular volume and then they will remain so throughout the inspiration. Here in the pressure control ventilation, the pressure has increased and they have remained so throughout the inspiration. So you get a square, almost a square box in a pressure time graph. Here in a flow time graph, since flow is nothing but it is volume upon time, you have fixed the volumes and the volumes have remained constant throughout the inspiration. So this is what you get, a square in a flow waveform, right? So this pattern is called as constant flows. The flows are constant during the inspiration. What is happening here? The flows are decaying during the inspiration. So these are decelerating flows. These are constant flows. Okay. So just look at this videotape and you would appreciate that there are square waveform in a flow time scaler, and here you have a pressure time scaler. Now in another video, here you have a decelerating flows and here you have a square waveform. Now I was talking about the advantage of one kind of a flow over the other. So the most important advantage that has been talked about in the literature between decelerating and the constant flows is these are your constant flows and these are your decelerating flows, is that the pressure which is required to deliver the same tidal volume, the pressure, just a minute please. The pressure which is required to deliver the same tidal volume remains low, is low for the decelerating flows. So least PIP 90% decrease. So in this slide, I've shown you that when you are ventilating a same patient on a volume controlled ventilation, the PIP was 29, vis-a-vis when you are ventilating this patient on a pressure controlled ventilation, then the peak pressures required were less. And the other very important advantages are the physiological, they are more physiological. So it is now preferable to use decelerating flows. Now, how it has been achieved? It has been achieved by a dual controlled ventilation, or what you commonly do is PCV-VG or PRVC, where you set the tidal volume, but at the same time you limit the pressure, and that is how you are ventilating a patient on a decelerating flows, but at the same time you are also guaranteeing the tidal volumes. Okay. The other very important component of a flow time scaler is your expiratory graph. See, among all the scalars, pressure time scalars, flow time scalar, and the volume time scalar, only the flow time scalar which gives you some information about the expiration. Now, remember one very important thing, that on a ventilator, expiration is always passive. So this expiration is basically determined by the compliance and of the lung and the resistance of the airways. So how can this waveform be useful for us? So as I just now told you, that it is going to tell you about some compliance, but mainly about the resistance of the airway, because the air is going to come out of your lungs. So you can look at the peak expiratory flows, slope of the expiratory limb. So this is a peak expiratory flows. Now looking at the slope is very important. Then the E time which is required, and whether the waveform, that is your expiration, touches the baseline or not. So this is these are some uses. These are some uses by which, these are some of the uses of flow time scaler. Suppose if your this expiratory limb does not touches the baseline and the inspiration starts, this shows that some air has been trapped, which usually happens during the obstructive airway disease, and the autopeep is being generated. Not just obstructive airway disease, guys, but also, if you will remember that if you are ventilating a patient of ARDS and if you have set the high peeps, then also autopeep may happen. So by looking at your flow time scalars, you can adjust your peep which you have set in even restrictive airway disease. The other important thing is that by looking at your obstructive, in obstructive airway disease, two things would happen. Your PF, which is, this is here, this will decrease, and your slope, it will be, longer slope. It may touch the slide, but it will be longer. And the other thing which you will appreciate here is that there is a lot of, there's a sudden decrease in pressure, and then gradually. So what has happened? Some air is able to pass out, and then because of the resistance, the other air is not able to come out. It is coming out slowly. So this is what is being depicted in the expiratory flow pattern in a flow time scalar. Okay. So moving to volume waveform, which is you see as volume or time scalar. As I told you before also, there is not much difference between the volume control and pressure control ventilation when you look at volume time scalar. However, it gives you some important information, and the most important information which volume waveform gives you is about the leaks. Now look at this video, and here you would see that this, the expiratory part of the volume waveform is not touching the baseline. Why it is not touching the baseline? Because there is a leak of 20-30%. So this is how you would look at the leaks, but air trapping and leak, it is difficult to differentiate in the volume controlled ventilation. But usually it is said that if, if it doesn't touches the baseline, just, plateaus, then this is what this volume gives you, that this is the air which is not being returned back to your exhalation port. because the sensor is at the exhalation port. So it is not able to sense that this much of air is missing. So it may be leak, it may be auto leak. Okay. The other important is active exhalation, which you can see in a volume time scaler. So I'm coming to loops. Loop is again very important. I'm sure this is a PV loop, which one is familiar with most of the time. Now in PV loop, one has to understand few things very important. So one is that on a x-axis, you have volume. On a y-axis, you have pressure. So what happens is that as the pressure is increased, you see the change in volume is very different. Now, per unit change in pressure causes less changes in the volume here. However, the per unit change in pressure is causing more changes in the volume. Can you appreciate this? I'm sure you can. So this becomes your lower inflection point, or the point from where many alveoli have come together, and or I would say many alveoli have recruited, and with some change in pressure, a large changes in volume is occurring. So this is the lower inflection point, and it is said that if you are able to determine the lower inflection point, and then you can optimize your PEEP. You just put lower inflection, whatever is the pressure at the lower inflection, +2 can be set as a PEEP. And then the point comes, see, then the point comes where the change in pressure is not causing much change in tidal volume. Again, see, there is a lot of difference, not much. Again, the change in pressure is not causing much change in tidal. So this is going to be your upper inflection point. That is, if you're going to increase the pressure further, that the benefits will not be much. In fact, you may cause some over distinction in some alveoli, and they may rupture, and there may be increased risk of lung injury. So the very important thing that is being taught by this PV loop is to work in the area where the change in pressure, where the per unit change in pressure is causing much more changes in the volume. That is you should be able to keep your lungs open even during expiration. Okay. So moving forward,
Dr. Ratna, kindly expedite.
Sir, I've already exceeded?
No, 5 more minutes. 5 more minutes, but I'm saying expedite, please.
Yeah, I'll do that.
Yeah.
So this is again very important, because we often forget that when we are, you have a spontaneous, when you are ventilating, when the patient is spontaneously breathing, then you have a negative pressure. This is negative, this is positive. So here is a negative and this is positive. Then this is a controlled ventilation and this is assisted. Assisted is when you are making some effort. So that effort would be negative. Okay. So this is what I have already explained. You just have to remember that in the previous, it was starting at 0. So no PEEP. If it is starting here, that means some PEEP has already been put. This I have already explained. Now, other important thing, which is very important, is that you should know when you are looking at your PV loops whether the patient is on pressure control ventilation or volume control ventilation. If it is pressure control ventilation, then it will be more of a square box. Again, a square box or a pregnant lady. That is what you see here. Otherwise, this is what is seen in a volume control ventilation. So uses of PV loop. Compliance. So once the compliance decreases, the PV loop will become flatter. That is what you have to remember. When the resistance increases, both inspiratory and the expiratory resistance increases, then it will become fatter. Here, this is a leak, that it is not recognized. It is not coming back to its original point. Broken in the midway is leak, and this is what is, it is coming back, but not to 0. This is trapping. Okay. Now I'm coming to flow volume. Again, this is very important. Flow volume is flow on the x-axis and the volume on the y-axis. So before I talk about this, you have to remember that in a spontaneously breathing, here is inspiration, which is negative, and this is expiration. Vis-a-vis, when I'm talking about positive pressure ventilation, the inspiration is positive and expiration is negative. This is what you should be able to remember. The other very important thing is that you should be, by looking at your flow volume loops, you should be able to discern that whether the child is on pressure control mode or a volume control mode. So this is a volume control mode because you can see a constant flows or a square waveform in a flow time scaler. So you will see the similar thing on the inspiration here on the flow volume. This is a flow volume loop. This is a flow time. So here we are just volume on the y-axis. Otherwise, this would remain same for both. This would remain same for both. So the only changes are in the expiration. Okay. So what information does the FV loop gives you? So by looking at the FV loops, again, the reduced peak flows, the scooping, this is obstructive airway disease. If it returns before it, the gap over here is the leak, and these are basically the secretions. Now I've come, this is like, there are few, whatever I have said just now. So I wanted to see how much I have been grasped. So just by this information, if you get this much of information on your ventilator, here you have a PIP and here you have a P-plat. The trans airway pressure is increased. So this is an increased resistance, right? Now, the increased resistance with flow volume loop. Don't look at the flow volume loop. Don't look at these graphs. Don't look at these graphs, please. So if you will look at this flow volume loop, then here the peak flow is decreased. The scalloping has occurred. The hysteresis, the PV loop has become fatter. So these three things, the increased trans airway pressure, the scalloping in the flow volume loop and decreased PEFR, peak flow rates, and a fat hysteresis says that this is a obstructive airway disease. Now, if you will look at this, where the trans airway pressure is decreased and the compliance here, look at the compliance, the PV loop has become flat towards the pressure. This means the compliance has worsened. Now, to determine the ortho-PEEP, you can look at the pressure time scaler, where you will see that the pressure is not, during exhalation, it has not come back to zero. The flow volume loop, the exhalation has not gone back to zero. And in a pressure PV loop, again, the exhalation has not returned to zero. Same air trapping can also be seen in a flow time scaler, where the expiration has not returned to zero. It has not returned and the new inspiration has started. Okay. So talking about leak, as I told you before, that in a leak, the PV loop will be broken. And in a volume time scaler, you can very well appreciate the air leak. So I'll stop. It's very difficult to do this kind of a graphics on a Zoom meeting. I would have preferred if you people would have been there, but still I would appreciate if there are any questions, and I would take that. I won't go further about more asynchrony. I'll just stop there. So basically, I would like to conclude by saying that graphics are very important. By looking just at the graphics, you can very much determine how your patient is doing on the ventilator settings you have put, and whether you need to sedate the patient or whether you need to make some changes to make the patient as synchronous as possible with the ventilator.
Thank you. Thank you, Dr. Rachna. I think this is one vast topic, as we all agree,
Yes,
because you look at the ventilator all the time as to what are the graphics doing, which way the loop is going. But I think what is important for everyone to understand is try to memorize the kind of image that you see repeatedly correlating with the patient. Once you have seen the patient doing asynchrony and that's how this is looking, or water in the circuit, or patient with bronchial asthma, or low compliance, that's how by practice you learn. But she has at least initiated you all into what all to look for, and continue to do that, because this is one thing that's not going to be available to you overnight to learn. But you have to sort of, it has a learning curve, but as long as you have a ventilator that has this graphic display, those graphics can really be sort of interpreted that way, and you don't have to do calculations. That is the best part now. In ventilator, you don't have to do much of a calculation. Ventilator does it for you because it has a computer built into it. But obviously, with the workshop, hands-on, people around the ventilator can do a lot of it. But right now, we'll get back to you right after this next talk. And then we have questions accumulating, and we'll address whatever best we can. So our next speaker for this, thank you, Rekna. You can stop screen share. Our next speaker for this evening is Dr. Anil Batra. He's a senior consultant neonatologist, trained DNB at Gangaram, as well as he's been a senior consultant neonatology at Rainbow Children's Hospital, along with Dr. Naveen. And he has also worked at Asian Hospital in Faridabad, and is quite extensively experienced. He is going to address, and hopefully he'll try to cover both newborns and pediatrics, even though he's a neonatologist, to talk about weaning, just the basic principles of weaning, extubation, and what's it routinely practiced. Dr. Anil, you could share your screen, please.
Yeah, good evening, everyone. Thank you, sir, for the nice words. Just like to share the screen.
Yeah. And meanwhile, some of the questions we have answered as they came on, but I'm sure there will be more questions. So we'll just open the two question answer live. But for now, Dr. Anil Batra, all yours.
Is the screen visible, sir?
Yes.
Yeah, good evening, everyone. I was just putting my views on about the weaning strategies and the extubation. My talk would most likely be basically upon the basically targeted about the neonatal population.
It's okay. It's all right. Yeah.
So as we all know that mechanical ventilation is not a nice thing, and it's very challenging, especially in preterm and in small babies, because we have to give small tidal volumes and with high breathing frequencies. And we are using, most of the times we're using uncuffed endotracheal tubes. And it has got both short-term as well as long-term complications. Short-term complications like atelectasis, aortic syndromes, pneumonias, and neurological morbidities. So all of us, we want that the baby should be taken out of ventilator as soon as possible. As Dr. Chandrasekhar very rightly discussed, that most of the ventilation these days is targeted towards non-invasive ventilation. So we also want that as soon as we put the baby on ventilator, the first target should be to take the tube as soon as possible. So how do we define weaning? By weaning, we mean that we gradually decrease the ventilatory support and transfer the respiratory control gradually towards the baby, eventually resulting in the discontinuation of the mechanical ventilation. So there are few principles of weaning. Weaning should be done aggressively, provided the baby is stable. And slow weaning is very dangerous because it can lead to excessive lung injury, because we are giving volutrauma as well as barotrauma. Also, low carbon dioxide levels have been shown to have harmful effect on the developing baby's brain. The weaning should not be attempted only during the morning rounds. It's an ongoing process. So at whatever point of time we feel that the baby's started to recover, so we should start to attempt weaning. Weaning should be started once the gas exchange is satisfactory and the work of breathing. If the clinician feels that the work of breathing is not excessive, we can start to wean. So there are some conditions which need to be fulfilled before we start to wean the baby. The most important is that the basic pathology which is responsible for the patient's respiratory failure has started to improve. For example, the baby who's a preterm, who's having hyaline membrane disease, we know that in 48 to 72 hours, the diuresis begins and the baby starts to pass excessive urine and lose weight. That's the time that we should be aggressive in weaning if the baby is on ventilator. The baby should be completely hemodynamically stable with either no vasopressor support or on minimal support. And the baby's oxygen requirement should not be much. They should be less than 30-35%, and a mean NV pressure requirement of less than 7 centimeters of water. The baby's neurological status, the baby should be neurologically active. The baby should not be extremely lethargic or comatose, because that baby is unlikely to sustain extubation. And the baby's muscle drive should be, muscular power should be fine. Babies who are having muscular disorders, they are more likely to fail weaning trial. And the babies should not be acidotic. The baby's electrolytes, especially the potassium levels, the calcium levels, they should be normal, because they are necessary for the proper muscular function. So weaning has got very much advantage, especially in babies who are small. In our trial, it has been shown that extremely preterm babies who are less than 1 kg and especially less than 28 weeks, there was a increased risk of BPD approximately 17-fold if they were extubated after 7 days compared to those babies who were extubated in the initial 2 to 3 days of life. So early weaning prevents, has got a protective effect on the baby's lungs in the long term. Also, when we take the baby off to a ventilator early, we are preventing nosocomial sepsis, pneumonias. We're improving the patient's comfort level. The need for sedation there's no need for sedation. And also it helps in the earlier transition of the baby from tube feeds to the oral feeding. Also for parents, it's a very nice feeling that the patient is come out of ventilator, and that helps in the parental bonding. So what are some strategies that we should apply when we are weaning the patient? So first important thing is we should assess that the baby is ready to be weaned. The settings, they should be decreased in small increments every 4 to 6 hours, depending upon whether the baby is tolerating weaning properly or not. The peak inspiratory pressure should not be decreased by more than 2 to 3 centimeters of water. The oxygen concentrations, they should not be decreased by more than 5 to 10% at the time. And FiO2 should be, first the FiO2 should be tapered to 60% before touching the other fields, because high oxygen levels of more than 60%, they have been shown to lead to lung injury because of generation of free oxygen radicals. The peak expiratory end pressure should not be, and expiratory pressure should not be decreased by more than 1 centimeter of water. And the rates can be decreased by 5 to 10 per minute. Weaning strategies depend upon what is the primary mode of ventilation the baby is on. Most of the units, they use SIMV mode, and some of the units, they're using assist control and pressure support ventilation modes. In case of SIMV modes, the rate should not be reduced until the peak inspiratory pressure has been reduced to less than 20 centimeters of water. In case of assist control modes and pressure support ventilatory modes, the rates are of the baby is generating, the ventilator is giving the breaths according to the baby's efforts and the baby's breathing rates. So we should try not to decrease the positive and expiratory pressure. We should keep the PEEP levels to an adequate level. We should lower the PEEP, PIP, the peak inspiratory pressure, and gradually transfer the work of the breathing to the infant. The backup rate should be decreased at the last, so that if the baby is having apneas, and we should know that the baby's breathing drive is sufficient to sustain extubation. Volume targeted ventilation has come in a very major way over the last few years, because in this, we target the volume. The volume, if the baby is on volume targeted mode, the ventilator adjusts the pressure to deliver a desired volume of oxygen air mixture. So if we set a ventilator tidal volume at a particular level and the baby's pathology starts improving, so the pressure becomes, or the pressure that is required to deliver that particular tidal volume, it is decreased gradually automatically. So in this, we can call it auto weaning takes place, because when the lungs become more compliant, so the amount of pressure that is required to deliver a particular tidal volume is less. So it avoids excessive tidal volume and achieves a shorter duration of mechanical ventilation. Never go down to tidal volumes of less than 3.5 to 4 ml per kg in neonates. And in pediatric patients, I think we're using 5 to 7 ml per kg. We should consider raising positive end expiratory pressure to maintain adequate distension of the lungs as the PIP comes down. High frequency ventilation, both pressure, amplitude as well as the mean airway pressure are reduced progressively as tolerated. If the oxygenation is well, we should decrease the mean airway pressure by 1 centimeter. And amplitude, if the PCO2 levels are, baby is washing carbon dioxide levels, then the amplitude can be decreased gradually. Frequency is never used as a means to reduce the support in high frequency oscillatory ventilation. So at which ventilatory settings the baby is required can be extubated comfortably. If the baby is on conventional ventilation and SIMV mode, at pressures of peak inspiratory pressure of less than 16, PEEP of less than 6, and at rates less than 20 per minute, provided the oxygen requirements are not more than 30%, we can comfortably take out the baby. For the baby is on assist control mode or pressure support mode, for babies who are less than 1 kg, the mean airway pressure should be less than 7 and the oxygen requirement should be less than 30%. For bigger babies, we can tolerate slightly higher MAPs of around 8 centimeters of water, and these babies can be taken out of ventilator. If the baby is on volume ventilation, if the tidal volumes is less than 4 ml per kg and the oxygen requirement is less than 30%, and the baby does not, the pressure requirement to deliver this much of tidal volume is not more than, say, less than 14 to 15, the baby can be easily taken off ventilator. Babies who are on high frequency ventilator, we are in a dilemma that whether we should take the baby, we can take the baby out of high frequency ventilator to directly nasal modes, or we should first switch to conventional ventilation. Various studies, they have shown that we can safely take the baby out of high frequency ventilator to the CPAP or nasal IMV modes. And it has been shown to be better as compared to, it decreases the duration of ventilator vis-a-vis when we shift the baby from high frequency to conventional ventilation and then to nasal modes. For babies less than 1 kg, a MAP requirement of less than 8 centimeter and an oxygen requirement of less than 30%, we can take the baby directly to nasal modes. And with the babies who are more than 1 kg, they can tolerate shifting to nasal modes at MAPs of less than 9 centimeters of water. So as we discussed that SIMV is the most widely used mode, and babies who are extubated from SIMV to nasal modes, if we add pressure support mode, they can be extubated significantly earlier as compared to the infants who are treated only with the SIMV mode. Babies who are alone on pressure support mode, it's easier for them to be weaned, but we should take care that we should be providing sufficient positive end expiratory pressure to maintain the lung volume recruitment. And meta-analysis by Klingenberg et al. In 2017 showed that volume targeted ventilation mode, it accelerates, there was trend towards accelerated weaning from mechanical ventilator as compared to the pressure targeted ventilation mode. So there are various strategies which help us in facilitating weaning: permissive hypercapnia and permissive hypoxemia. Permissive hypercapnia is based on the philosophy that we can tolerate higher levels of PCO2s, and higher levels of PCO2s, they are not harmful for the baby. But our recent trial, which was published in 2015, Felbit trial, it compared two levels of PCO2. In the high target group, they had PCO2s of 55 to 65 on the postnatal days 1 to 3rd in one group. From day 4 to day 6, that PCO2 targets were 60 to 70. And from day 7 to day 14, the targets were 65 to 75. The control group had lower PCO2 targets, 40 to 50 on the first to third day, 45 to 55 on day 4 to day 6, and 50 to 60 between day 7 to day 14. The trial enrolled approximately 400 neonates, and it showed that the rates of combined outcome of BPD or death in the group which had targeted higher PCO2 levels, they were more. So there was trend towards higher morbidity of BPD and mortality in the higher PCO2 groups. Also, there was slightly higher incidence of grade 3 to 4 intraventricular hemorrhage. So the recent recommendations are that we should not be targeting PCO2s very higher levels, but between 40 to 50 on day 1 to day 3, and if the baby is more than 1 week of age, then PCO2s levels of up to 60 can be targeted. So mild degrees of permissive hypercapnia is safe and effective in reducing the need for mechanical ventilation. Similarly, initially around 10-15 years back, there was trend that we should be tolerating lower oxygen saturation targets because they were associated with lesser degree of retinopathy of prematurity, lesser chronic lung disease, and faster weaning from mechanical ventilation. However, a meta-analysis which took into account a support trial, 3 boost 2 trials, and the Canadian oxygen trial involving total of 4,911 infants, in which they had compared whether low oxygen targets, that is between 85 to 89%, vis-a-vis high oxygen targets, that is 91 to 95% within the first 24 hours. What was the effect on the various morbidities and mortalities? They found that there was an increased risk of mortality and NAC in the babies who were targeted towards lower oxygen saturation. However, there was a reduced risk of ROP, but that was at the cost of increased risk of mortality. There were no other differences in the BPD, brain injury, or PDA. So the present saturation targets, they should be maintained between 90 to 95% in infants with less than 28 weeks of gestational age. So we should not be targeting saturations of less than 90%. All the units, they should have a weaning protocol. Use of weaning protocols, it has been demonstrated to improve weaning, especially in adult and pediatric patients. There was a survey which was carried out in Brazil in various neonatal ICUs, PICUs, and combined ICUs, in which 146 hospitals were questionnaires, they were taken into account. And weaning protocols were applied in 57% of the unit. And the most common lay employed protocol in NICUs was standardized gradual withdrawal from weaning support based on the clinician judgment. In case of PICUs, spontaneous breathing trial was occupied. And whatever is the information available, I suppose that in neonates, especially in smaller babies, the spontaneous breathing trial has got a very limited role, and it is more of useful in adult patients and in pediatric populations. Clinical evaluations and ABG analysis, they are used as a criteria to assess the readiness for extubation. Adjunctive therapies like caffeine, use of systemic steroids, and adequate nutritional support, they have been shown to be useful. Caffeine, we are using prophylactically in all the babies, extremely low birth weight babies, and that has been shown to improve the outcomes such as extubation failure, and the number of days on invasive and non-invasive ventilation. We use in a dose of 20 milligram per kg loading dose and followed by 10 milligram per kg of maintenance dose. Use of steroids, systemic steroids in the first week should be discouraged because it increases the risk of both short-term as well as long-term complications. A later use after first week of life can be practiced because it decreases the mortality and decreases the risk of BPD in smaller babies. Adequate nutritional support, early use of parental nutrition goes a long way in helping the babies to be weaned off ventilation. Other adjunctive therapies like use of diuretics, closure of ductus, routine use of sedation, and physiotherapy are used on and off on an individual basis. They are they don't have a definitive role in the weaning process. So how do we define weaning success? We define that once we take the baby out of ventilator support, the baby tolerates extubation for at least 48 hours. And weaning failure is defined as the failure of spontaneous breathing trial test or the need of re-intubation within the first 48 hours after extubation. The parents, it's important that we counsel the parents that the baby is likely can suffer weaning failure, especially in very preterm babies or in babies who are intubated for a prolonged period of time. So what should be the extubation procedure? 2 persons should be present once the extubation is planned. And, the baby should be on monitor and the baby should be stabilized before the extubation. The oxygen level should be monitored. A person who is skilled in intubation should be readily available before the extubation is tried. The one feed should be withheld or the baby should be fed at least 1 hour before the extubation is tried. Ensure that you have got all the working equipment, laryngoscope, endotracheal tube, suction in place. And babies who are smaller babies and the babies who are on prolonged ventilator, we usually shift them on nasal modes, nasal CPAP mode or nasal IMV mode to prevent extubation failure. Baby who has been undergone a short duration of ventilation or a bigger term baby, that can be directly weaned to room air. So if we are dealing with a difficult intubation or prolonged intubation, then we should have nasal CPAP and the nasal ventilation setup ready. Place the infant in the supine position with the head in the midline. Suction the endotracheal tube, the oropharynx, and the nares. Use an adhesive remover to remove the tapes, and you can use a manual ventilation through the ventilator to give a baby inspiration, or we can transiently increase the FO2 requirement before extubating the baby for few breaths. Then withdraw the endotracheal tube smoothly, and if the nasal CPAP is required, then we should apply it promptly and secure it. Suction the pharynx as required, and we need to monitor the infant closely for the next few hours once we extubate the baby. Watch for increased work of breathing, oxygen levels, the oxygen requirements, and if required, if we feel that the baby's work of breathing is increasing or the settings are increasing, then we can get a chest X-ray and record a blood gas to look for any collapses and the acid base status. So the key elements of post-extubation management include a respiratory support that I discussed about CPAP, nasal IMV, or in smaller babies, we can use heated humidified high flow nasal cannula. Adjunctive therapies like caffeine. In case of stridor, we can use epinephrine. Physiotherapy can be used in case of borderline babies to prevent them for re-intubation, and inhaled steroids, they can be tried. So what should be the criteria if your extubation has failed? How do you know that your extubation has failed? Any apnea which requires positive pressure ventilation, multiple of babies having repeated apneas, 1 per hour, which means that 6 per, with babies having 6 apneas in 6 hours, and the baby needs to be ventilated because we don't want to have the baby in shock. If the oxygen requirements are again rising and the baby requires more than 50% oxygen to maintain saturations of more than 80 to 90%, or if blood gas, we find that the PCO2 levels, they are increasing to more than 60 with a pH of less than 7.2. And if the baby is having excessive work of breathing with severe retractions, that again becomes a criteria for re-intubation. So there are various specific as well as general risk factors for extubation failure. If the baby is overtly sedated, the baby has prolonged intubations, the baby is suffering from some neurological disorder, the baby is having some airway abnormalities like cleft lip, cleft palate, the baby is having acidosis, the baby is in sepsis, or the baby is not hemodynamically stable, these babies are at more chances for extubation failure. In newborn babies, babies who are extremely preterm, less than 26-27 weeks, male babies having intraventricular bleed leading to depressed sensorium, babies having a large ductus, and suppose someone baby gets self-extubated from high ventilatory settings, and if after extubation, if we don't provide adequate positive end expiratory pressure, to expand the lungs, that baby is more likely to suffer extubation failure. Thank you.
Thank you very much, Dr. Anil. It was a very exhaustive, nice review. And I think I'll very quickly jump to Dr. Rajiv Uttam to just say a few comments about weaning in pediatrics, because you have predominantly talked about weaning in newborns. As to how weaning in pediatrics is different, just briefly, because the audience would want to know the pediatric aspect, and then we'll move on to some of the other questions that have accumulated. Dr. Uttam.
Thanks, Praveen. As Anil has said, in neonate, the difference between pediatrics is there are different diseases, you wean off for. If the child does not have...
And may I request all the panelists to please turn your videos on and audio on. Rajiv, please go on.
Okay. So if you have a child who have normal lungs and normal heart, you have just ventilated him with the normal lungs, you do not have to wean him slowly. You just put him on a spontaneous breathing, and if he is well, he is conscious. There are few requisites which you need for a child to be weaned and eventually extubated. The primary pathology has to get better. It should be hemodynamically stable. There should not be too many electrolyte abnormalities, and he should be conscious enough to maintain his airway. If you have a child you have ventilated for ARDS or any chronic lung disease, the biggest problem is that you try to wean him too soon. You extubate him and then he goes back on ventilator again. Or you have a child who is on a ventilator, who is on steroids, who has got a gram-negative sepsis. Those children have a very predominant critical illness neuromyopathy as well. So you have to keep it in mind. Every child you do for a prolonged ventilation for the lungs and the cardiac issue, you got to wean them slowly. It means come down on FiO2, take them from pressure control or a control mechanical ventilation to SIMV, then pressure support, and eventually you do a spontaneous breathing trial. You put them on a T-piece for 10 to 15 minutes, see their heart rate, their blood pressure. If they're not having tachycardia or bradycardia, and the child is not sweating, their blood pressure is maintained and saturation is okay, it means he's ready for extubation. The moment you put anyone on ventilator and reduce the setting, that is called weaning in itself. But the eventual weaning is that the child is on minimal support, is awake, neurologically he's all right, he's following commands, he's got a good muscle strength, and he does not have too much copious secretions. If all is taken care of, then the child is ready for spontaneous breathing trial and then eventual extubation.
Thank you. Thank you, Rajiv. There's a question from Dr. Priyanka Gupta. What is the expected transpulmonary pressure? And this is to Dr. Rachna. Dr. Rachna?
Yes, sir. The transpulmonary pressure actually has been derived as a factor which can help you to ventilate the patient. So expected transpulmonary pressure is usually considered to be somewhere around 13 to 15.
I see.
Okay. Safe would be, below 30.
And one question is for Dr. Naveen. Is there any role of caffeine? Actually, this is for Dr. Anil Batra right after his weaning talk. Any role of caffeine during extubation in full-term neonates?
No, sir. There is no role of routine use of caffeine in case of full-term neonates because apnea is uncommon in full-term neonates. So routinely we don't use caffeine.
And one specific question that came up for Dr. Naveen, it's actually about the NIV, the CPAP in a group of patients below 28 weeks, 28 to 30 weeks, 30 to 34 weeks, and 34 weeks to term. So it's a sort of exhaustive question, but I'm sure Naveen will clarify it.
Yeah, thanks, sir. Thanks. So in less than 28 weeks, when we are dealing with ELBW babies, we understand that the RDS is the main problem. So we put the baby first on CPAP. Now, sometime these babies, they may require CPAP for a longer period of time. Always remember that in the initial few days, when the RDS is severe, then CPAP provides a good descending pressure. So it is a better alternative than high flow. But suppose the primary pathology of CPAP has gone, but baby is requiring this CPAP now for suppose he is 2 weeks old and he's requiring it for desaturations apnea. At that point of time, you switch to high flow and see if that works. In the same baby, suppose you have to intubate the baby and give surfactant. And then in the post-extubation phase, you can use high flow. But remember, if your baby is failing on high flow, then before re-intubating, go through the CPAP pathway, because 15-20% of these babies, they will be okay on CPAP and you can avoid the re-intubation. Coming to second stata of 28 to 34 weeks. Average age, as the gestational age advances, the duration of CPAP requirement for primary RDS decreases. Like 32 weeks usually will require CPAP for 4-5 days. So for primary mode, again, CPAP is the best strategy. For post-extubation, suppose the baby needs intubation and then given surfactant and then extubated, then you can always use high flow. More than 34 weeks, majority of the babies, they do well on the CPAP. So 34 weeks till term, your CPAP provides a better distending pressure, and it is a better strategy as compared to high flow.
Okay, thank you. See, in our unit, ever since we have started, like Dr. Chandrasekhar presented the data on high flow, ever since we have started and we have collected prospective data since 2017, the overall average reduction in the ventilation in at least the pediatric age group, 1 month to 17 years, has come down by 30%. So I think 30% is a significant, and this made us, we were talking about the criteria of ventilated patients for a PICU. Many of the PICU said, sir, आजकल तो हम लोग कम ventilate कर रहे हैं because we are putting them on high flow CPAP and BiPAP and sometimes just get away without any ventilation. Any comments, Dr. Chandrasekhar? Please unmute yourself. Please unmute, Dr. Chandrasekhar. About the data from our unit about this high flow nasal cannula.
Yeah, so actually we have presented some data in the World Congress in Mexico. So as Dr. Khilani said, so after using the high flow nasal cannula, the principle is you should use the high flow as early as possible rather than waiting, patient goes to the severe respiratory distress. And if you start early, actually, you can significantly decrease the number of invasive ventilations. So this data shows almost there is 30% reduction of invasive ventilation by using a high flow nasal cannula as early as possible. Even even if you have a facility to start, even you can start in the emergency itself. But we don't have that provision. But we shift the patient quickly in the PICU and we start the high flow nasal cannula as early as possible in pediatric ICU.
And what about your experience, Dr. Rajiv, and then followed by Dr. Rachna?
I think more or less same, Praveen. Since BiPAP and lately high flow has come, almost all bronchiolitis patients get better on that. Post extubation as well, high flow is really good. People who used to be extubated and then go on re-intubation, you put them on a high flow or you put them on a BiPAP prospectively after extubation, they do much better. So our invasive ventilation rate has come down by 30 to 40% as well, using this sort of modality, which is really good, which we started with the neonates, and now it is much part of the PICU overall.
See, the big information that I want to give is talking to our adult colleagues like Dr. Rajesh Pandey, Rajesh Chawla, all of these people who are dealing with lots of COVID patients. High flow has been used along with proning in many of the patients. So coming back to pediatrics, Dr. Rachna, what about BLK experience of HFNC?
I will agree with what Dr. Uttam and Dr. Chandrasekhar has said, that our invasive ventilation rate has gone down to 50-60%. And the most important thing which I have seen is that now we are brave enough to take the child or to wean the child off invasive ventilation to non-invasive ventilation, and that is reduce the rate of ventilator associated pneumonias. And also, rehabilitation of the child starts quite early vis-a-vis what we used to do earlier in the in an earlier era, around 10 years back.
So is Dr. Ankur on?
Yes, sir.
Dr. Ankur, what about when you take the patients off the babies off the ventilator, are you taking them on high flow, or are you taking them on straight, or what's the usual strategy? Are you putting them on CPAP when you are extubating the patient from ventilator? Baby, let's talk about neonates.
That's a very important question, sir. So it's very clear and evidence is in favor that, so if your patient is on any invasive mode of ventilation, like conventional mechanical ventilation, you try to extubate the baby as soon as possible and put the baby on non-invasive mode of ventilation. So here non-invasive would be NIMB. Generally, we use a non-synchronous intermittent mandatory ventilation, NIV or NIMB. So what they have found that if you use NIMB compares with CPAP or high flow, the chances of reintubation would be less. So for extubation per post-extubation, NIV is the primary mode of ventilation. So yes, CPAP is closer to NIV, but definitely not high flow ventilation.
So while I have you, since from pediatric literature, a lot of time this issue comes up, we want to check the patient for extubation readiness. Is there any such thing that you all follow in newborns, or it was just a general criteria? Like, for example, steroids and
no, sir. Generally, it's a general criteria. What Dr. Anil has told, that baby should be alert, active, and there should not be any sedation during the last 24 to 48 hours. There should not be any secretion in the ET tube. There should not be any pneumonia. And if the baby is very low birth weight, like we told that you should give caffeine before extubation. Definitely not in a higher dose, because most of the baby would be getting caffeine for their prevention of apnea prematurity.
But for term, you're not using caffeine, right?
No,
that's the point.
Definitely.
Okay.
Definitely.
Okay. So one more question. This is for Dr. Uttam. The question that was brought up was that as to why do you need to use low respiratory rate in asthma?
Right. I think we just need to remember what is asthma. Expiratory obstruction. It means their expiratory obstruction needs more time to exhalation. And if you remember, if you have a high respiratory rate, you need to give more inspiratory time and expiratory time. So low rate will allow you to get your expiratory time much long enough for any trapped air to come out. That's why you have a low rate and a higher expiratory time.
Okay. All right. And I'm just trying to read one more question that has come up. Let's see. I think there was one question. Yes. What is the incidence of ventilator-acquired pneumonia with each additional day of ventilation? I think that's a very good question that has been brought out. And that's what making us all try to minimize the days of ventilation, while when it is necessary, you have to do it. But as soon as the patient doesn't need it, you should wean off, because each ventilator days add to it. So any of the panelists can comment on that. How does it increase the risk of ventilator-associated pneumonia by additional day of ventilation?
I don't think probably there is any 10%, but obviously the longer it remains, the more chances of it becomes. You know, your invasive line going in, you have a central lines, arterial lines taking care of invasive ventilation, and this regular suctioning happening. So there is going to be a breach of sterility at any time you do. So increasing anything beyond 3 or 4 days is going to create a problem. I don't think there is any published evidence that you have 10% each day or 5% each day, but obviously with each passing day, it increases obviously compared to if you were to extubate him early.
One Dr. Deepak is asking, what is the ideal I/E ratio in RDS? I am imagining he's talking about the neonatal RDS, but we can answer both ARDS and RDS of newborn. So any neonatologist can take this up. I/E ratio that you keep in patients with RDS.
So in newborn RDS, sir, basically we don't go with the I/E ratio. We try to target the TI and the rate. So normally in preterm babies, roughly a TI of 0.3 is sufficient. and in term babies, 0.35 is okay. And we set a rate between 40 to 60. So
I see.
sometimes, although the computer, the ventilator is showing that the IE's ratio is 1:3, but it's not that 3 times the inspiratory time the expiration is going on. Usually you
I
will
see.
see that the inspiratory and expiratory times calculated by the machine are more or less the same. Expiratory will be slightly longer. But in between the two breaths, the baby can take his spontaneous breath. That is why if your suppose preset rate is 40, you will see that the baby is breathing at a rate of 70 when we are not paralyzing the child.
I see. And then the ARDS, Dr. Ratna? ARDS, what's the I2E ratio?
So basically, one should remember that eye time is one modality by which you can improve oxygenation. So for all purposes, you can start with 1:2, but if it is difficult or if you want to improve oxygenation, you can increase your eye time. That is, you can go back to 1:1.5, 1:1.1 even, and even less than that. And less than that is something what we are talking as APRV mode, where we are basically increasing the eye time to such an extent that the oxygenation may become predominantly better.
Praveen, again, sorry, Vishnu.
Yeah.
Again, I think the same thing which Naveen has said. We don't go too much on the ratio. It is the eye time. Anything you start with 0.7, 0.8, you need to remember the time constant in ARDS is very, very, less compared to the status asthmaticus. So anything you start with your eye time of 0.7, 0.8, and your respiratory rate, I think, is good enough. And as Rachna has said, you got to see if your eye time is low, and you want to increase your MAP by increasing your eye time, then oxygenation will get better.
Now, Dr. Pradhum BA is asking, preterm baby on venti having PDA, what should be the strategy to close PDA?
Right. So,
yeah.
Dr.
It's not a ventilatory question, but it's okay. I think we should address that. Yeah.
So, Dr. Pradyum, as in neonatology, majority of the things, like we have become more aggressive to more and more conservative. Nowadays, if I will say that in 2000, we were closing, suppose 10 ductus, now we are closing 1 ductus, or even lesser than that.
Surgically, you mean?
Sir,
or
not, sir, even medically.
Medically.
Even
okay.
medically.
Okay.
So now
okay.
ductus is considered as an innocuous bystander. However, mainly less than 27 weeker baby. So there are some kids who have a really significant ductus, and there is a significant amount of pulmonary overperfusion and systemic hypoperfusion going on. And you feel that the baby is having, you are not able to feed the child. So, and you are not able to take the baby off ventilator. So in such cases, you give the medical closure. And for medical closure in India, we don't have the IV ibuprofen, but the study says that oral brufen is also good. So you can use oral brufen. There have been studies now on IV paracetamol, but there conflicting results are there. Some study shows equivalent, some studies shows that IV paracetamol, the closure rate is slightly less. So brufen will be a good choice, but always remember that your duct should be really significant. It's not that duct is visible on the echo and you tend to close it, because majority of them will get closed on its own, on their own.
So, Dr. Chandrasekhar, the question that is addressed to you is that suppose you have a patient with myocarditis and is having a severe congestive heart failure. Is it better to do diuretics or go on to ventilation? Please unmute yourself. Yeah. Unmute, Dr. Chandrasekhar.
Chandrasekhar, unmute your thing.
Unmute on your computer. You're muted.
Yeah.
Okay.
Yes.
So
yes.
Regarding the question of using diuretics or BiPAP, the NIV, so see, they both have a different mechanism of action. So if you using a diuretics, basically you are decreasing the preload, right? And when you give a positive pressure, so you are decreasing the afterload. So basically, I mean to say, if there is a significant cardiac failure, I will use both diuretics as well as the BiPAP to prevent the intubation, invasive ventilation.
And I think I would add to it that if the cardiac contractility is low, then I think we should also give inotropes, like as you would do for a support.
Definitely.
So all three,
Yeah.
preload, inotropic, as well as afterload reduction by doing the ventilation.
Positive pressure, yeah.
Yeah, I think just one more question. Let me just bring this up. Preterm, this. Okay, yeah. How is, Dr. Rajiv, this is a question for you. How is pneumonia different from ARDS?
Let's put it this way.
Nothing to laugh about. You know, I think no question is a good question.
I
So,
think
yeah,
if
very
you
important
remember,
question brought up. Yeah.
No, I think if you remember the reason I'm laughing is all the time ARDS is referred as bilateral pneumonia, because
That's
you
right.
have a bilateral infiltrate.
Double pneumonia.
Double pneumonia, you have double pneumonia. So all
Yeah.
pneumonia are not ARDS, and not ARDS is because of pneumonia. So pneumonia is an infection, as we know, of a lung parenchyma. It may or may not lead to ARDS. Leading to ARDS means pneumonia is bad enough for you to cause hypoxemic failure and with the bilateral chest infiltrates. But ARDS could be pulmonary or extrapulmonary. For ARDS with pneumonia, you need antibiotics like you would use for any pneumonia, and then your ventilation strategy would be different than if you were just ventilating someone with a pneumonia. So pneumonia can lead to ARDS, and pneumonia can be just pneumonia not leading to ARDS.
And it's a low compliance disease.
Low compliance.
So that, yeah. So I think we have addressed most of the questions. I would request any of Dr. Nub or Dr. Smita, who may be on, so we can just do a little session. Yes. So on behalf of PCNI, I would really like to thank, as a course director, to all the esteemed speakers. And this is an exemplary attendance. Usually people come like 30, 40 or something. This was 102 right from the beginning. And then there's an entire different, many of the hundreds who are on Facebook. So I am glad that this session is being recorded. I'm glad that PowerPoint presentations also. So just as a verbal consent, I would like all of you to say that if somebody wants to take a look at your presentation, you don't have any issues.
Please do so.
Okay. And so I'd really thank Dr. Rajiv, Dr. Chandrasekhar, Dr. Naveen, Dr. Anil, Dr. Rachana, Dr. Ankur, and Dr. Nab and Dr. Smita Mishra, who's the president and secretary, respectively, for allowing us to conduct this workshop. It's a short notice, but still there are lots of people who have attended, and I'm so glad to see the response and the kind of material that was brought out. Thank you very much, and hope that we will have some physical workshops also. But with these video clips, I think it was very helpful for the people to get that practical aspect of, feeling of a workshop, even though there were PPTs. Thank you all. Thank you very much.
Thanks very much, Praveen. You handled it so beautifully as always. And all the esteemed speakers, our friends who have not met for a long time because of COVID. And, it's such a joy to see them at least on the screen. And we hope to see you all guys again physically. And have a safe and happy, the Corona days.
Corona days. Yes.
Congratulations, Dr. Uttam.
Thank you.
Yeah.
Okay, bye-bye.
Yeah. Once again, congratulations, Dr. Uttam, for getting elected as a VC unanimously. There was no contest about his position. So that's so nice. So now he will be in charge for 62 centers in India, running the IDPCCM, IFPCCM fellowship.
You gave editors, Praveen, but you're going to be there, so it's all right.
Definitely.
So, sir, waiting for party after the Corona.
Yeah.
Party.
So thank
you.
Thank you all the delegates who have attended this session, and any of the speakers. If you all have any questions, you can also directly contact them and WhatsApp them. And as always, we are always available.
And thanks Rohit Malhotra for his beautiful support during the thing. Thank you.
Yeah.
Bye-bye.
Thank you.
Thank you.
Thank you. Yeah.